I just, in terms of some of the organization, I did create some Pearl slides at the end of kind of each section so that I'm hoping like a few days before the test, you may be able to look at those quickly, and those really have key points, and then you could, kind of scan those a few minutes, and just a few minutes, and hopefully that'll help you on the test. So this is just the outline. We don't really need to go through this except to say that we're going to kind of do luminal GI first, and then we're going to end with liver. And let's get going with the esophagus. So let's start off with dysphagia. So that is basically swallowing that does not proceed appropriately. And really the history could aid in the diagnosis. And the key thing you want to distinguish is whether it's solid or liquid dysphagia. And you also want to make sure that the patient doesn't have odynophagia, which is pain with swallowing. So there are really three types of dysphagia. There's transfer dysphagia, which is oropharyngeal, and that's seen in neurological conditions like stroke and Parkinson's. And then there's anatomical issues like a Schatzki's ring or cancer. And then there's motility, which is a peristalsis issue and or failure to relax the lower esophageal sphincter. So history is really important when making these distinctions. So if you see coughing and gagging and things like that, it's really consistent with oropharyngeal or transfer dysphagia. If patients have solid food dysphagia and liquid dysphagia, then generally that's going to be a motility or a neurologic issue. If they have intermittent solid food dysphagia, that's really consistent with the Schatzki's ring. So people in that case could get meat stuck and then be fine for a few months, then have it happen again. If the dysphagia is progressive, starting with solids and then liquids, it implies that there's something in the esophagus that's progressively narrowing, and that would be consistent with like a peptic stricture or cancer. And you can see the summary slide down here, which you could review on your own, that basically reiterates what I just said. So a young male with solid food impaction, that would be highly concerning for something, for an entity called eosinophilic esophagitis, which I'm sure you've all heard of. I'm going to go into a little bit more detail on that. If there's odynophagia at the same time as dysphagia, that's pretty typical of pill-induced esophagitis. And some of the classic medicines associated with this would be doxycycline and alendronate, although there are a number of others that could do this as well. So with regards to testing, there are a variety of tests that are available. So usually we do an EGD, which would be kind of the first test performed. Sometimes we do a barium swallow either before the EGD, kind of as a roadmap to see if we could see a stricture or diverticula or something like that. Or we may do it after an EGD is done if we need more anatomical information. There's something called a video fluoroscopic swallow study, and basically this is also referred to as a modified barium swallow. And what people do is they ingest barium, and then you take a video and you can kind of see how the anatomy is working together to get the food bolus back into the upper esophagus. And then there's esophageal manometry, which is a test that evaluates for motility disorder, so it looks how the esophagus contracts. So we do have a new technology called high-resolution manometry, which really provides more information than traditional manometry, and I have some examples of that. So here's the first question. A 47-year-old presents with persistent and progressive dysphagia over the last 2 years. His wife says he's complained of heartburn more and more, and last month he had an episode of regurgitation, and she insisted he come in for evaluation. A chest x-ray at a local urgent care was done, and it showed absence of the gastric air bubble. So which diagnosis is most likely? So we'll start the countdown here. All right, so this is kind of a wide distribution. The answer is achalasia. And the real tip-off for that is the absence of the gastric air bubble. That's kind of a tip-off that achalasia would be present. Adenocarcinoma of the esophagus could present in a similar way, but achalasia would be the best answer. And as an aside, we do, in the back of your syllabus, I have detailed explanations of all the answers to the question, so you could look at that, and that'll give you more information. So achalasia is neuronal denervation and ganglion cell degeneration of the myenteric plexus. And what this leads to is absence of organized peristalsis in the esophagus. And the classic thing that it does is it leads to incomplete relaxation of the lower esophageal sphincter. So basically what happens is you have loss of inhibitory ganglion that normally produce nitric oxide. So on the flip side of that, there's sparing of the cholinergic neurons that cause contraction. And one of the reasons we use Botox as a treatment for achalasia is that it could actually poison these excitatory neurons. So that's kind of a good way to remember it. So characteristic features for achalasia would be dysphagia for both solids and liquids. Remember I said motility disorders, you're usually going to see both of those things. You could have regurgitation, and you could also have a variety of other symptoms. So diagnosis could be made with a few modalities. So classically, people would do a barium swallow, and you could see the bird's beak here, this narrowing. If you see that on a test, that is classic for achalasia. An endoscopy is almost always done, and that helps rule out a tumor and rule out other etiologies. And then esophageal manometry would classically show no peristalsis and a non-relaxing lower esophageal sphincter. It's worthwhile to mention that there's something called pseudoachalasia, which basically mimics achalasia, except that the cause is a tumor that's involving the neuronal plexus in that area. And it could actually also be part of a paraneoplastic syndrome. So there are a variety of cancers that could do this, including gastric esophageal cancer and others. And the presentation of the manometry could appear very similar to achalasia. So if you have particularly an older patient that would be higher risk of malignancy, you really want to think that pseudoachalasia could be the cause, and it may not necessarily be traditional achalasia. And in these cases, we usually do a CAT scan of the chest or an endoscopic ultrasound to rule out a cancer. So treatments for achalasia involve pneumatic balloon dilation, usually to pretty high levels, up to 3 or 4 centimeters. There's about a 5% risk of perforation with that. You could also do a surgical myotomy. And then there's endoscopic Botox for higher risk patients where you may not want to do invasive things like surgery or balloon dilation. The treatment decisions really depend on the age of the patient and the comorbidities. So generally, if a patient is younger and healthier, you may want to go for more of a surgical approach. If the patient's older, a lot of comorbidities, then Botox would probably be the least invasive option. So to talk a little bit more about neurologic disorders with dysphagia. So here we see dysphagia for solids and liquids from the beginning. So examples of this: stroke, Parkinson's, ALS, MS. Because there's a transfer issue getting the bolus back from the mouth to the back of the throat, patients may complain of choking, gagging, and regurgitation. And when we're concerned about this, we really want to get a video fluoroscopy study or a modified barium swallow. Again, this is where you swallow barium and you can actually see what's going on when they swallow. In some cases, you may have to put a PEG or a PEG in for nutrition purposes, but as we all know, this will not prevent aspiration of oral secretions. So there is an entity called diffuse or distal esophageal spasm. The old term was diffuse, and now it's called distal. And what we see here is simultaneous, uncoordinated, non-peristaltic contractions. And this is an example of a pure motility disorder. So you'll see intermittent dysphagia for solids and liquids, especially cold liquids. That tends to trigger the condition. So if you see that on a test, that would be a tip-off for that. And often atypical chest pain is follows the dysphagia symptoms. Reflux symptoms can mimic DES symptoms, so in some cases we'll treat with a PPI if you suspect that there may be superimposed GERD. If you were to do a barium swallow, you may see a quote-unquote corkscrew pattern. Again, that would be a tip-off on a test. And then there are a variety of medicines that could be used for this, so diltiazem would be one of the first-line medications, and even Botox can be done in some cases. So I do want to focus a little bit on manometry because this is being used frequently now. So there was the older standard manometry, and now over the past, I'd say 6 or 7 years, there's high def or high resolution manometry. And just if you ever see any of these tracings, you need to know just some general principles. And I have a picture of this afterwards, but if on the manometry tracing, if you see purple and red, that indicates areas of high pressure. Blue is areas of low pressure, and again, I have a photo on the next slide. And then there's something called the Chicago classification, which helps classify the different motility disorders. And really, it starts with the esophageal gastric junction. If there's impaired, e.g. Esophageal gastric junction relaxation, that's consistent with achalasia. And if there's normal relaxation, then that's consistent with a number of other motility disorders. So 2 of the most common would be distal esophageal spasm, which we just discussed, which is uncoordinated simultaneous contractions, and something called jackhammer esophagus, where there's very vigorous contractions. So here is an example of a normal swallow. So this is the upper esophageal sphincter here. So when you swallow, it relaxes, and so it's blue. Remember I said before that blue is low pressure. And then you could see over time, the contraction is going down the length of the esophagus. So the length here is on the y-axis. And then here you could see an example of distal esophageal spasm. You see how all of the red is kind of clustered and you're not getting this nice propagation down. So this is an example of distal esophageal spasm. With regards to anatomic obstruction, like for example, cancer, strictures, or Schatzki's ring, usually you'll have dysphagia to solids, definitely in the case of a Schatzki's ring, and then liquids afterwards, particularly in the case of a peptic stricture or malignancy. And in younger patients with intermittent symptoms, it would be more of a tip-off that you're dealing with a Schatzki's ring. So Schatzki's ring specifically, usually patients complain of issues with meat, sometimes with bread. It used to be referred to as steakhouse syndrome. And a lot of times the patient will give a history of regurgitating the meat up. So they'll be in a steakhouse restaurant, and then all of a sudden they have this horrible feeling, and then they regurgitate it back up. Unfortunately, if they can't regurgitate it back up, they come into the emergency room, and it's a major issue, and we have to go down endoscopically and remove the meat. And that happens, unfortunately, very frequently. The key number to remember in terms of how narrow it could be before a ring becomes symptomatic is 13 millimeters. So that's a key number. And generally, you treat by dilating the ring with a balloon. We could do that during endoscopy, and then adding PPI afterwards, because PPI therapy has been shown to decrease the recurrence of a Schatzki's ring. So an esophageal stricture, as we've discussed, it's a history of slowly progressive constant dysphagia for solid food, and then it may lead to liquids as well. There may be a long history of incompletely treated acid reflux, so that would be a risk factor for a peptic stricture and also, frankly, for esophageal cancer. In some cases, patients may have prolonged NG tube use, like if they're in the hospital for a long period of time, or even lye ingestion, which could lead to alkali injury to the esophagus and can cause a stricture. Fortunately, these are more rare these days because of PPI therapy, which could prevent these acid or peptic strictures. But if they are present, generally we use long-term PPI, and we could dilate the stricture with serial balloon dilations during endoscopy. On malignant obstruction, really, there are two main causes of esophageal cancer. There are two subtypes. There would be adenocarcinoma and squamous cell carcinoma. Sometimes you could actually get extrinsic compression from the mediastinum pushing in on the esophagus. And generally, you'll see a history of slowly progressive dysphagia to solids, then soft food, then liquid. So the key here is if there's dysphagia and weight loss, it's really esophageal cancer until proven otherwise. So when you're seeing patients in your clinic or the hospital, that's what you want to rule out. There's an entity called Plummer-Vinson syndrome. You probably remember this from medical school. This could show up on a test potentially. It's one of these rare things, that they like to hone in on. So this is a rare disorder of dysphagia due to an upper esophageal web. So a Schatzki's ring is a lower esophageal web, whereas in this syndrome, it's in the upper esophagus. Classically, it's found in postmenopausal women. It's associated with iron deficiency anemia, which it's felt that the iron deficiency may in some way be playing a role in the formation of the ring. And importantly, there's an increased risk of squamous cell carcinoma in this syndrome. So the triad is dysphagia, upper esophageal web, and iron deficiency anemia. If you see this on a test, it's Plummer-Vinson syndrome. It's worthwhile to mention scleroderma and systemic sclerosis. So when scleroderma involves internal organs, it's called systemic sclerosis. This leads to atrophy of the smooth muscle in the distal two-thirds of the esophagus. And this leads to not only weakened peristalsis, but could also affect the lower esophageal sphincter. So a lot of times when we do endoscopy in patients with scleroderma, we'll just see a wide open lower esophageal sphincter, and you may see esophagitis because acid gets up and irritates the lower esophagus. Question number 2. A 26-year-old man presents with intermittent solid food impaction. Regularly when he eats a bite of meat, he feels like it doesn't go down completely. For the next 30 minutes, he can't even swallow liquids, sounds miserable. He finally brings up the piece of meat and is able to swallow afterwards. He denies heartburn or any other GI symptoms. He does have seasonal allergies, important point, hint, for which he takes over-the-counter medications. Which of the following do you recommend? EGD, omeprazole, prednisone, barium swallow, or referral to an allergist? Okay, so we got the countdown. All right, good. Most people got this. So this is really classic for eosinophilic esophagitis. The tip-off in that question is the seasonal allergies. So that would be the best answer. It could also be, consistent with other things, even a Schatzki's ring. But the allergies is really the tip off. And when you have dysphagia like that, you really want to take a look down there with an endoscopy as kind of your first line testing. So eosinophilic esophagitis. So this is what it looks like when we do an endoscopy. So you see these stacked circular rings, which is also called a quote unquote feline esophagus. If you take biopsies, it will reveal generally greater than 15 eosinophils per high power field under the microscope, so that's kind of the cutoff. You could also see increased eosinophils in GERD, but they're usually less than 5 per high power field. So the key number, 15 or higher, eosinophilic esophagitis, and if you see this picture on a test. So classically, patients have solid food dysphagia and food impaction. Demographically, frequently young men, often a history of allergies, sometimes a history of asthma. So treatment, there is something called PPI responsive eosinophilic esophagitis, where the patient has clinical and histological EOE, but they respond to PPI. The pathogenesis is not completely clear, but sometimes we do start off with PPI to see if this will work. If that doesn't work, we usually use swallowed steroids such as fluticasone or viscous budesonide, and patients really could respond pretty dramatically to this. And a key point here is that you should refer the patient to an allergist because there may be a food allergy that's playing a major role, and with an elimination diet, you may be able to save the patient a lot of problems going forward. So that's actually an American College of Gastroenterology recommendation. Question number 3, a 17-year-old high school girl, previously healthy, presents to the office with pain with swallowing. This has been present for 1 day with a sudden onset. There is no history of heartburn. It's an important point. Past medical history is significant for taking OCPs and doxycycline for acne. Physical exam is normal. What is the next test? Or what is the best recommendation? CT chest, EGD, barium swallow, fluconazole, or stop doxycycline and give reassurance? So let's see what we got here. Great, everyone pretty much got that. So doxycycline, classic drug associated with pill esophagitis, young person, no other alarm symptoms. So really, reassurance is the best thing here. If there are other concerning symptoms, if it's been going on for a while, there's weight loss, hematemesis, things like that, you may want to do an EGD, but in this case, you could just stop the medicine and give reassurance and it should go away. Some miscellaneous causes of esophagitis to consider. So if you have odynophagia, as we discussed, it could be pill-induced, but it could also be infectious. So the pill-induced we already went over, and the treatment is really to stop the offending medicine, like doxycycline in this case. Again, another classic one would be alendronate. There are a number of infections that could cause esophagitis that could be associated with dysphagia and odynophagia. So some of the key ones would be Candida, HSV, and CMV, particularly when you're dealing with immunosuppressed patients, AIDS patients. So generally Candida, if there's dysphagia and no improvement with empiric antifungals like oral fluconazole, you may need to do an EGD with biopsy. I should mention that there's not always 100% correlation between oral thrush and esophageal candidiasis, so that's a key point. And generally your threshold for an EGD is going to be lower if there's no thrush because you may be less likely to know what you're dealing with. So it could be CMV or HSV and you want to go down and see. But a lot of times you could just empirically treat them, particularly if they have oral thrush, and see how they do. So let's switch gears a little bit and talk about GERD, one of the most common disorders people see in their clinics. So this is due to lower esophageal pressure being decreased by a variety of factors. There are dietary factors like chocolate, alcohol, fat in a fatty diet, smoking, anticholinergics, and pregnancy could also be associated with GERD. There's also something called transient lower esophageal sphincter relaxations. These happen in everybody. And this could lead to GERD in anybody, even if there's not one of these other inciting factors up here that I was discussing. So classic symptoms would be heartburn, so discomfort kind of in the lower chest radiating upwards, and sometimes sensation of regurgitation or symptoms of regurgitation. There are a number of extra esophageal manifestations of GERD that you need to pay attention to because sometimes people won't have classic heartburn, but they may have some of these other symptoms or signs, and so that could be a tip-off for you in your clinic or on a test. So if you see loss of dental enamel, if there's constant hoarseness and throat clearing, if there's chronic cough, a globus sensation, that's a really, really common symptom that we see. Non-cardiac chest pain, 70% of that is actually caused by GERD. And then even exacerbation of asthma. So if you have a stable asthmatic and suddenly they're getting more exacerbations and there's no infection, you may want to consider that that patient may have GERD that's superimposed. So diagnosis of GERD, a lot of times you just put the patient on an anti-acid medicine such as PPI, particularly if there are no alarm symptoms, and see if they get better. However, if they have alarm symptoms, so we all know these, right? Dysphagia, dynaphagia, weight loss, anemia, blood in vomitus, iron deficiency anemia, or even failure to respond to a PPI, then you're probably going to send the patient for an EGD. So there are a number of different guidelines from different societies, but generally, if you have those above alarm symptoms, you're going to want to send the patient for an EGD and you want to refer them to a gastroenterologist for further evaluation. Also, if a patient has chronic GERD and they have risk factor for Barrett's esophagus, which we're going to get into, and esophageal cancer, such risk factors would be older age, male, smoking, and obesity, then that would be a tip-off that you want to send the patient for EGD as well. Question number 4. A 50-year-old female complains of 1 year of daily hoarseness. She has frequent non-cardiac chest pain with nocturnal heartburn despite use of ranitidine, which obviously is not a PPI, it's an H2 blocker. She denies dysphagia and weight loss. There's no help with an allergist and ENT for the hoarseness. You recommend EGD now, manometry, pantoprazole, or ranitidine. Okay, let's see what we got here. All right, good, that's great. So most people got that. So she's fairly young, no alarm symptoms, we suspect extraintestinal manifestations of GERD, so the PPI can not only help with diagnosis, but also obviously could be therapeutic as well. So, you know, in the absence of alarm symptoms, you probably wouldn't need to do an EGD at this time. And then ranitidine is an H2 blocker, and that's not going to be particularly helpful in the long term. So treatment of GERD, if you just have mild to moderate GERD, you could get away with kind of lifestyle interventions like raising the head of the bed, weight loss, small meals. If you have more severe symptoms or you actually have esophagitis on an endoscopy, then you really want to use PPI as opposed to H2 blockers. PPIs could heal esophagitis in up to 95% of cases, but H2 blockers really don't heal the esophagus very well. When you're talking about surgery for GERD, so fundoplication, generally it's going to be used in young patients that want to avoid long-term PPI use, but this is a key point. You want to do fundoplication in people that actually respond to a PPI. If they're not responding to the PPI, they're probably not going to respond to a fundoplication. So that's a key point. Another key point is that even after you do a fundoplication, studies have shown that about 60% will still require a PPI therapy postoperatively, maybe months or years down the line, but a lot of them will require PPI. And another key point is you want to do a motility study before you operate on somebody because you want to make sure that their esophagus contracts normally, because if you seal up the esophagus with a fundoplication and they have a motility disorder, then you're going to have a major problem with symptomatology. Other treatments for GERD, so Reglan, too many side effects not used, sulcralfate, sometimes you'll see, you know, historically you may see people on this, but it's not very helpful. H2 blockers are typically ineffective in the long term because they have something called tachyphylaxis, which means that after a few days they stop working, then you have to kind of take a break from the medicine and restart it. PPIs do not have tachyphylaxis, so PPIs are really good for long-term therapy. People with atypical symptoms like the patient in the question may take a little bit longer to respond to treatment and may require more aggressive treatment, like BID PPI as opposed to Q-day PPI. So a little word on PPIs because these are so common. They could cause a mild increase in gastrin level that's really clinically insignificant. There is a short-term risk of increased community-acquired pneumonia. There's probably an increased risk of bone fracture, and some of the studies are unclear whether there's real causality there, but there's definitely an association. One key thing that PPIs could do is they could lead to very low magnesium levels in patients, and that could lead to muscle spasms, arrhythmias, and seizures. I've seen several cases of that. It also increases your risk for C. diff. So you really want to discuss the risk benefits of PPI with your patients, and you want to make sure that the indication is really there, and you want to keep them on the lowest effective dose for the shortest amount of time. And then in terms of this question that came up several years ago, whether it interferes with Plavix, the answer is no. So that's, and this is the trial that showed that. So there's no significant cardiovascular harm when you have people on concurrent PPI and Plavix. Question number 5, a 55-year-old male patient with a BMI of 40 is seeing you for follow-up of long-standing reflux, poorly controlled with daily H2 blocker, so he's not on PPI. He's doing well and has no complaints. He undergoes an EGD at your request to rule out Barrett's, and he's found to have a 2-centimeter segment of Barrett's with biopsies positive for intestinal metaplasia, but key, no dysplasia. He wants to know when his follow-up endoscopy schedule should be. So Barrett's is pretty common, so you're probably going to see a lot of these patients in your clinic. This is just a picture of the salmon-colored mucosa that's kind of typical of Barrett's. This is the lower esophagus here, and this, you can see this extending upwards. So you recommend which of the following? Repeat exam in 3 to 5 years and switch to PPI. Repeat exam yearly and continue H2 blocker. Treat with RFA and continue H2 blocker. Or there's no dysplasia, so we really don't need to do anything. Give you a little time to answer that one. All right, let's see. Great, everyone got that. So obviously you need to follow these patients, and the guidelines are to repeat it in 3 to 5 years. If there is dysplasia, it may have to be done earlier. And the other issue is you want to put the person on PPI because that could actually decrease the risk of dysplasia going forward. So Barrett's esophagus. So this is a change in the cell type in the lower esophagus at the GE junction from squamous, which is normally present, to specialized intestinal columnar epithelium. And what that means is that when you look at it under the microscope, it shows intestinal metaplasia with goblet cells. Goblet cells is the tip-off that Barrett's is present. Importantly, a lot of patients may not have any symptoms of GERD. So you may be doing EGD for a different reason, and then you just happen to find Barrett's. There's a higher risk, however, of having Barrett's in Caucasian males greater than 50, BMI greater than 30, long-standing GERD, smoking, and a known hiatal hernia. Barrett's is associated with approximately 30 times risk for esophageal adenocarcinoma, and what that equates to is if you have Barrett's, you have about a 0.1 to 0.4% chance of developing esophageal adenocarcinoma. So it's fairly low, but a real number. So we need to monitor these patients. And as I mentioned, key point, PPI can decrease risk of dysplasia in Barrett's. So if you have any patients with Barrett's in your clinic and they're not on a PPI, they need to be put on a PPI. Surveillance, the answer to that question, there was no dysplasia, so it's 3 to 5 years, okay? If there's something called low-grade dysplasia, the first thing you want to do is confirm that this would be more something that I would do as a gastroenterologist, is confirm that the dysplasia is actually present with 2 different pathologists. And then you really want to repeat the EGD, take more biopsies. If there are any lumps or bumps there, you want to take those off with endoscopic mucosal resection, because there could actually be cancer. You may just be biopsying the top that shows low-grade dysplasia, but if you actually remove the nodule, there could be cancer underneath. And then you really want to refer to a therapeutic endoscopist to actually ablate the rest of the Barrett's, generally with something called radiofrequency ablation. So that's the treatment for low-grade dysplasia. If you have high-grade dysplasia, fairly similar, you want to repeat the EGD, take more frequent biopsies at shorter centimeter intervals. You want to confirm it with 2 pathologists. Again, you want to remove any nodules with endoscopic mucosal resection, which we can do during EGD. And again, that's to make sure that there's no frank cancer. You want to ablate the rest of the Barrett's with radiofrequency ablation. And then if there's actually cancer there, then it's possible that the patient may need a esophagectomy. So it kind of depends on how deep it is. Sometimes we could actually take a cancerous nodule out if it's a very early stage with EMR during endoscopy, but sometimes if it's deeper, more extensive, the patient may need surgery. So esophageal cancers, there are really 2 types. There's adenocarcinoma and squamous cell. So generally adenocarcinoma is in the distal third of the esophagus and squamous is in the proximal third, okay? The risk factors are similar but slightly different for these 2 types. So for adenocarcinoma, there's risk factors would be Barrett's esophagus. There's a higher risk in Caucasians, GERD, and smoking. For squamous cell, this is more commonly seen in African Americans and Asian countries and is also caused by smoking and alcohol. This is a nasty picture of an esophageal cancer here. And as I mentioned, sometimes we're able to treat much smaller cancers than this with endoscopic mucosal resection. If they're larger, they may need esophagectomy and chemo and radiation treatment. If the disease is advanced, generally you'll treat with radiotherapy and surgery, or no surgery if the patient's not a candidate. Question number 6. An elderly patient from the local nursing home is sent to your office after regurgitating undigested food. The sitter says the food looked like rice and beans, sounds like a New Orleans meal, from 2 days ago. In the office, you notice the patient's breath is quite foul, kind of a key point there. How would you like to proceed? Barium swallow, refer to GI to consider EGD, PPI therapy, or ignore it because it just happened once? Good, most people got that too. So the answer is barium swallow because you're actually worried about a Zenker's diverticulum, so the food kind of getting caught and being regurgitated, the foul smell, that's consistent with the Zenker's. Actually, an EGD could be dangerous on the Zenker's because you could put the tip of the scope right through it and lead to mediastinitis. So really the first thing to do if you suspect this clinically would be to do a barium study. So Zenker's diverticulum, outpouching of the hypopharynx, you could see it right here on this x-ray. So here's the upper esophageal sphincter, and then you could see this outpouching collecting barium. So really what's going on is there's herniation of esophageal mucosa between the cricopharyngeus muscle and the inferopharyngeal constrictor muscles. Too much information, I know. Treatment options include endoscopic therapies versus surgery versus cricopharyngeal myotomy. It kind of depends on how the comorbidities of the patient. But we do have endoscopic therapies that are available for this. So here's the first Pearl slide. So I'm hoping, again, that you guys could read this right before the test. So dysphagia to solids and liquids, motility disorder, right, like achalasia, neurologic, or a cancerous stricture. Those would be typical for dysphagia to solids and liquids. Remember, pseudoachalasia, cancer mimics achalasia. We discussed this. Treatment for eosinophilic esophagitis would be PPI if there's eosinophilic responsive eosinophilic esophagitis. However, we often use swallowed steroids, and then we send the patient to an allergist to discuss an elimination diet. Remember, if you're doing a fundoplication for treatment of GERD, you need a pre-op motility study to make sure that there's not a problem with swallowing before you do that tight wrap. Patients having a higher risk of Barrett's include Caucasian males greater than 50, BMI greater than 30, long-standing GERD, smoking, and a known hiatal hernia. And remember, PPIs decrease dysplasia in people with Barrett's. So if you have patients with Barrett's, make sure you're renewing their PPI therapy, or if that's an answer on the test. All right, so now we're going to do the stomach. So we'll talk about physiology, then talk a little bit about dyspepsia, gastritis, and H. pylori. So normal physiology, keep this simple. So there are G cells in the antrum that release gastrin in response to vagal stimulation, amino acids, and gastric distension. Gastrin, in turn, causes parietal cells to secrete acid into the lumen. Gastrin also stimulates ECL cells to produce histamine. So that's why we sometimes use histamine blockers. Somatostatin and secretin both decrease production of gastrin, so it's kind of a feedback mechanism. And in the absence of stomach acid, gastrin levels will increase dramatically. So for example, if you're on PPI therapy, you're going to lose acid in your stomach and your gastrin's going to go up. It can cause very, very high gastrin levels, but generally the gastrin will go up to maybe like 150 or something like that with a PPI therapy. It's usually not quite to 500, but it could happen. Dyspepsia, this is a non-specific term, right? This can mean a variety of different things. It can mean postprandial fullness to some patients, early satiety to others, epigastric discomfort, heartburn, and gnawing pain. And there's also a variety of different causes to a patient with dyspeptic symptoms. It could be due to an ulcer, gastritis, GERD, gastroparesis, NSAID use, or maybe we don't find anything. If you have new onset unexplained dyspepsia, the classic teaching was that if you are greater than 40 to 50 years old, you would get an EGD. However, there are some new American College of Gastroenterology guidelines that we could go over to follow. So I have that coming up. In the setting of alarm symptoms, so if there's dysphagia, unexplained weight loss, evidence of GI bleeding, obviously you would want to do an EGD in that situation. Here are the new ACG guidelines from 2017. So they kind of switched things around a little bit. They said that in patients 60 years or older presenting with dyspepsia, you should do an upper endoscopy or an EGD. And then they state it's a conditional recommendation and that patients at higher risk of malignancy, for example, if you spend your childhood in a high-risk gastric cancer region or there's a family history, you may be able to, you should potentially offer endoscopy at a younger age. They also state that alarm features should not automatically precipitate endoscopy in younger patients, but this should be considered on a case-by-case basis, and that's a conditional recommendation. So I know a lot of people would be hesitant to not send somebody with an alarm symptoms for an EGD, but I thought you would want to see the guidelines that are out there. The manuscript does note, however, that epigastric radiating to the back and dysphagia and weight loss are symptoms that would fall out of these guidelines because this is no longer dyspepsia, right? If you have pain radiating to the back or dysphagia, that's concern for pancreatic disease or esophageal cancer, you're not dealing with dyspepsia anymore. So then you're going to go down a different pathway and you're going to send that person for an EGD. If patients truly have dyspeptic symptoms and nothing really specific, and they're under age 60, you could do a non-invasive H. pylori test and then treat if positive. Those that have a negative H. pylori test or do not respond to this approach could be given a trial of a PPI. And again, as with all guidelines, clinical decisions should be based on individual patient factors. We all know that. So gastritis, two main types. There's type A, which is in the body of the fundus, the body and fundus, and this is usually associated with atrophic gastritis. So classic example of this would be pernicious anemia. In pernicious anemia, you see antibodies to the acid-producing parietal cells and also to intrinsic factor, which is why we could see B12 deficiency in patients with pernicious anemia. And then there's type B gastritis, which is in the antrum, and that's the most common form of gastritis, and it's associated with H. pylori. There's a few points down here that achlorhydria could actually affect the absorption of different kinds of drugs. That's there if you want to look at that. Gastritis, there are a number of other causes aside from H. pylori and pernicious anemia. Probably the most common would be NSAIDs. Alcohol could also cause gastritis, as can severe physiologic stress, such as major surgery or burns. It's important, and there are some important circumstances to consider gastric acid suppression for prophylaxis to prevent any issues such as frank ulcer formation or bleeding. This would include prolonged mechanical ventilation, coagulopathy, or severe burns. The most effective treatment for stress-related mucosal bleeding or ulcers would be IV PPI specifically. So you have to make the distinction between prophylaxis and actual treatment. Question number 7. A 35-year-old male complains of belching and fullness after meals. He has no significant pain. It has never awakened him from sleep. He denies any heartburn or dysphagia. Past medical history is normal. There's no NSAID use. Physical exam unremarkable. Social history negative. Review of systems is negative. Which of the following do you recommend based on the slides that I just presented? Upper GI series, EGD, abdominal CT scan, H. pylori testing and treatment if positive, or PPI such as omeprazole for 1 month. Great. So so the best answer is H. pylori testing and treatment if positive. So those are kind of based on the ACG guidelines. So this person has dyspepsia, right? That there's no dysphagia, there's no pain radiating to the back that would be freaking you out in your clinic. And the first step really is to check for H. pylori and treat if positive. And then afterwards, if that doesn't work, you could try PPI. But I could see why some people might say PPI. But according to the guidelines, it would be H. pylori test and treat first. If the patient had concerning alarm symptoms, you'd probably send them for an EGD before you would do anything else. So H. pylori can cause a variety of things, including gastritis, peptic ulcer disease, cancer, and something called gastric B-cell malt lymphoma. 50% of the world may be infected, very, very high rates. So kind of slam dunks as to when you would test for H. pylori would be if you have a history of PUD or or you actually have PUD, like for example on an endoscopy, if you have a history of duodenitis, if you find malt lymphoma on endoscopy, if you have a family history of gastric cancer, there's some thought that H. pylori may be transmitted among family members and it could increase someone else's risk for gastric cancer. And then the dyspeptic patients that we were talking about before based on the ACG guidelines. So how do you test for H. pylori? There are a number of different ways. You could do a gastric biopsy, which is done during an endoscopy. So you look for the H. pylori by staining the tissue. You could also do a gastric biopsy for a urease test. So basically what happens in this situation is that H. pylori can hydrolyze carbon isotope labeled urea to CO2 and ammonia, and you're able to look for the radio-labeled CO2 on the biopsy. Then there's some non-invasive ways, so you could do a urea breath test as opposed to a urea biopsy. You could do an HP stool antigen, which I'm sure most people are very familiar with. Serology, no good, right? Serology, all it does is tell you whether the patient may have been exposed to H. pylori in the past. It does not tell you if the person has active disease, so that is not the answer. PPIs and H. pylori. So this is a key slide. PPIs could cause false negatives for pretty much all those tests except for the serum antibody, which you don't use anyway. So it could cause a false negative for urease, biopsy or breath testing, gastric biopsies, and the HP stool antigen. So generally what you want to do is you want to hold the PPI for 2 weeks before you order any of these tests. And then confirmation of eradication should only be done greater than 4 weeks after completion of antibiotic therapy for the H. pylori. These are key points. So treatment for H. pylori, so I'm sure people are familiar with this. One of the most common would be omeprazole, clarithromycin, and amoxicillin. Generally, we give this if there's no risk for macrolide resistance, although macrolide resistance is becoming more common. If there's a penicillin allergy, you're probably going to give metronidazole, clarithromycin, and PPI. And then if there are, in fact, macrolide resistance concerns, you could give PPI, bismuth, metronidazole, and tetracycline. And then salvage therapy means if the person failed the first attempt, then you often will treat them with bismuth, metronidazole, tetracycline, and PPI. There are some other salvage therapies. Sometimes people fail two therapies, unfortunately, and then you may give them something like levofloxacin, amoxicillin, and PPI. These are the most common regimens that you're going to see in clinical practice. All right, another question. Same patient, 35-year-old male with dyspepsia. He was H. pylori positive and received triple therapy. 2 months later in the office, he feels better. He wants to know if the infection was eradicated. Which test would you recommend to do this? EGD with biopsies, H. pylori antibody or serology, HP stool antigen, or an upper GI series? All right, let's see what we got here. Great, pretty much everyone got that. So you could theoretically do an EGD, right? But that's pretty invasive, so you don't need to do that in this case. The serology is not helpful. Remember, we were just discussing that because it doesn't say whether, it just says whether you're exposed. It doesn't say whether the bacteria is still there. Upper GI series is not going to help because you can't at all tell if H. pylori is there. You have to do a specific test for it. The upper GI series just gives you a general sense of the anatomy of the stomach. So who needs confirmation of cure greater than 4 weeks later? So any patient, traditionally it's been any patient with H. pylori associated ulcers, persistent dyspepsia despite test and treat strategies, anyone with malt lymphoma or gastric cancer. Again, do not use serologies. Do not use serologies. The ACG guidelines in 2017 take this a step further and they make it pretty simple. They say that whenever H. pylori infection is identified and treated, testing to prove eradication should be performed using any number of these tests at least 4 weeks after completion of antibiotic therapy and after PPI therapy has been held for 1 to 2 weeks. So basically, and according to the ACG, if you have H. pylori and you're treated for it, you need to make sure that it's gone. And remember, PPIs cause false negatives, so you want the patient off the PPI probably for 2 weeks. ACG says 1 to 2 weeks, but I think 2 weeks is the better answer. Peptic ulcer disease. So before we're kind of talking about gastritis, now we're going to shift and talk specifically about ulcers. So the two most common causes of this would be H. pylori and NSAIDs. And in fact, for people on NSAIDs, even though it may be subclinical, about 25% of people, if you scope them, would actually have ulcers in their stomach from NSAID use. And there's not necessarily a correlation between these ulcers and symptoms. Other causes of peptic ulcer disease would be Zollinger-Ellison syndrome or gastronoma, which we're going to discuss later. And then Crohn's disease of the stomach and duodenum could also cause peptic ulcer disease. And remember, cancer, adenocarcinoma, could cause ulcers of the stomach as well. So just to talk about NSAIDs specifically, these are very common medicines, so it's important that we understand the risks associated with this. So the highest risk for peptic ulcer disease in the setting of NSAIDs would be during the first 3 months of use, high doses, patient of advanced age. If the patient already has a history of an ulcer complication, such as a GI bleed, if there's concurrent use of corticosteroids or aspirin, if they have serious medical illness. Alcohol is kind of a tough one. Alcohol in itself doesn't really cause ulcers, but it can cause gastritis. And then importantly, corticosteroids alone really have a very small risk of causing ulcers, but if they're used in combination with NSAIDs, they significantly increase the risk of ulcer development and complications. So treatment of non-bleeding ulcers. So there are really 3 major strategies. Obviously, if H. pylori is present, we're going to treat it. You want to decrease acid secretion, which means putting the patient on a PPI, and you want to stop any exacerbating processes. So if the person's taking tons of ibuprofen or something like that, you're going to want to stop that. As I mentioned before, sucralfate and antacids are really not used that frequently anymore. PPIs are really first line of therapy. So this is just a slide kind of talking about how long you really need to treat various ulcers. Duodenal ulcers are usually due to H. pylori and NSAIDs, as we've alluded to before. If you have H. pylori and an uncomplicated duodenal ulcer, meaning there's like no stricture or bleeding, generally you could just treat the H. pylori and then that's that. You don't even have to put them on a PPI afterwards. If you have H. pylori and a complicated duodenal ulcer, for example, if there's a duodenal stricture, bleeding, etc., you're really going to want to put the patient on PPI for about 1 to 2 months after the H. pylori has been eradicated. If you have H. pylori and a gastric ulcer, generally you do want to treat with PPI for about 2 to 3 months after the H. pylori has been treated. And NSAID-associated ulcers are often treated with PPI for at least 8 weeks. I should mention that it's important to repeat the endoscopy in many cases of a gastric ulcer, particularly if it's large or concerning looking, or you didn't take enough biopsies to begin with because cancers can ulcerate. And sometimes you could actually get a false negative biopsy. So generally we'll go back in a few months to make sure everything healed up, to make sure there's no cancer that we missed initially. Question number 8. You are called to the emergency department to evaluate a patient with severe epigastric pain. On examination, he displays rebound tenderness. He reports taking high-dose NSAIDs, and a perforated ulcer is suspected. What test would you order to evaluate? EGD, upper GI series, CT of the abdomen, or an abdominal X-ray? Good. Yeah, most people got this. Yeah, abdominal X-ray is done first because it's the easiest thing to do. You can just get an X-ray right away. It's very quick, and then you can see if there's free air. It's not unreasonable to do a CT scan. That obviously is going to give you a lot of information as well, but really, if the person has peritoneal signs, you want to get the test done that you could get done in a few minutes. EGD would not be a good idea if you suspect a perforation because you could blow air through there and make things worse. Because the EGD scope has kind of air and water that comes out the tip, and that could go into the peritoneal cavity, so you wouldn't want to do that. So here's a X-ray showing free air under the diaphragm. So that's key tip-off that there's been a perforation. Indications for surgery in peptic ulcer disease, obviously if there's a perforation, which we just discussed. However, if you have an upper GI bleed that we can't control endoscopically, then surgery may be needed. Fortunately, with a lot of equipment we have now with endoscopy, that's pretty unusual, but it does happen. For uncontrollable upper GI bleeds, a lot of times we use IR before we do surgery because we could embolize, like for example, the gastroduodenal artery if that's bleeding and we can't control that with clips and cautery. If you have gastric outlet obstruction that we can't dilate with a balloon, if that's not working, the patient may need surgery. If you have recurrent or refractory ulcers, these are pretty rare. Surgery may be needed. And then if you have Zollinger-Ellison syndrome or a gastronoma causing ulcers, you would need surgery for the underlying tumor, not really for the ulcers in the stomach or the duodenum. So Bleeding peptic ulcers specifically, NSAIDs are the leading cause of bleeding ulcers. H. pylori is also an important cause of bleeding. Examples of when NSAID-related bleeding ulcer risk is higher would include older patients, concurrent aspirin or steroids, and a history of prior ulcers. I do want to mention COX-2 inhibitors that do have decreased GI side effects. Unfortunately, if you add aspirin to a COX-2 inhibitor, that leads to the same risk of regular doses of NSAIDs. So aspirin takes away the benefits of a COX-2. So everyone needs to know that. That's key point. Okay. Prevention of NSAID-related ulcer complications with prophylactic PPI. This was an important paper that came out in the American Journal of Gastroenterology a few years ago. A lot of people have patients on NSAIDs in their clinics, so you need to understand when you need to put a patient on a prophylactic PPI. So if the patient is considered high risk, meaning they have a history of prior complicated peptic ulcer disease or greater than 2 general risk factors below, so the risk factors would be age greater than 65, high doses of NSAIDs, prior uncomplicated ulcers, concurrent aspirin, steroids, or anticoagulants. So if the patient is high risk, you really want to avoid NSAIDs altogether, okay? If they're moderate risk, meaning that they only have 1 to 2 risk factors as below, then you really should be putting them on a prophylactic PPI. So that's a lot of people, right? So there are a lot of people that are young and on a high dose NSAID. Those people should be on prophylactic PPI. If the patient is older and they're on like a low dose NSAID, those patients would need prophylactic PPI. And then there are some patients that are low risk, so that would be like a really young patient on low dose NSAIDs, right? That patient may not need prophylactic PPI. But this is very, very common, and if people follow these guidelines, it'll prevent people coming in with GI bleeding and major complications from ulcer disease. Question number 9. A 62-year-old male comes in with melena for the past 3 days. He takes daily aspirin for coronary artery disease. Hemoglobin isn't too bad. It's at about 12. Vital signs are okay. PPI drip is started. The GI doctor comes in, does an EGD, and finds a clean-based ulcer. So clean-based. Which of the following do you recommend? Consider discharge in AM if no further bleeding. Keep on IV PPI for 72 hours. Tell patients to never take aspirin again. Refer to IR because bleeding is likely to restart. Let's see what everyone thinks. Great, most people got this too. Okay, so the key here is that the ulcer is clean-based. All right, clean-based ulcers, as determined by what the GI doctor sees and should write in the report, have an exceedingly low risk of rebleeding. So those people could really be discharged home. Clean-based means that there probably was a vessel there, but everything a bleeding vessel, but everything kind of healed up. And so the risk of things getting worse are very low, and you could discharge that patient home. So workup for bleeding peptic ulcers. So EGD is the first thing that we do. There are certain things that you need to know when you're reading an EGD report. So in terms of the risk of rebleed. So if there's an actively bleeding visible vessel that's treated at the time of endoscopy, the rebleeding rate could be as high as 55%. If there's a visible vessel seen but it's not bleeding at the time of endoscopy, the rebleeding rate could be 43%. If you see a clot in the area of the ulcer, the rebleeding rate could be 22%, and if it's a clean-based ulcer, it's well under 10%, which is why, in these cases, we could discharge the patient home. So treatment, endoscopic treatment, it's important people know a little bit about this. So the key here is that the best results are with combination therapy. So generally, we inject epinephrine into the ulcer base, and after that, we either use a cautery probe to kind of ablate a visible vessel, or we clip the ulcer closed. But the key is combination. So it's epinephrine plus cautery or clip. And also, you want to put the patient on IV PPI because that'll cause clot stabilization, and that could be very beneficial. So here you see this is the fundus of the stomach. This is the scope coming out of the lower esophageal sphincter and kind of hooking back and looking back on itself. And you can see this gigantic ulcer here. There's a lot of clot here. It's not actively bleeding, but there's some old clot here. So this has a pretty high risk of rebleeding. And in fact, this could be cancer given the size of this and the way the margins are irregular. Some non-ulcer causes of upper GI bleeding, so there's Osler-Weber-Rendo disease or hereditary hemorrhagic telangiectasia. So in these cases, you'll see telangiectasias on the skin, in the mouth, throughout the GI tract. Bleeding AVMs commonly occur in the stomach and the duodenum, and the patient may have a history of epistaxis. That's kind of a tip-off for that. And then there's Peutz-Jeghers syndrome, which is hamartomatous polyps found between the stomach and the rectum. A lot of times you'll see dark melanin spots on the lips and the buccal mucosa. There's a little bit more in this. I have some more slides on this, but the polyps could cause acute and chronic GI bleeding, so you just have to keep your eyes out for that, particularly in a younger patient. So it's a hereditary form of cancer, hereditary cancer syndrome. Other issues involved in GI bleeding, you may see people talking about video capsule endoscopy. So that's a pill with a camera on it that a patient's able to swallow. It courses down the small bowel and it generates like tens of thousands of pictures. That is like, the worst nightmare to read for us because we have to like literally look at 20 or 30,000 photos of the small bowel. But it's high yield. You could see AVMs, polyps, tumors, things like that. Generally, you're going to do that if you do an EGD and a colonoscopy and you don't figure out what the cause of bleeding is. And then if you find something on the capsule, the video capsule, we now have balloon enteroscopy, which is this special endoscope, long endoscope that kind of threads its way down all the way through the small bowel. So you can actually directly visualize the entire small bowel endoscopically, and that'll allow you to intervene on something that you may have seen on a capsule. So if you saw bleeding AVM in the distal jejunum, which traditionally would be completely out of the reach of any endoscope, you could send the patient for a balloon enteroscopy and they can actually get at it. So that's good news. So Zollinger-Ellison syndrome or gastrinoma, we've already had a few slides on this. So this is a tumor that secretes gastrin and hence leads to high acid output in the stomach. This leads to diarrhea and steatorrhea. The reason it leads to steatorrhea is because the acid denatures lipase and other pancreatic enzymes. It also causes post-bulbar duodenal ulcers, which are fairly uncommon. So if you see ulcers in the second and third portion of the duodenum, that's a tip-off that you could be dealing with the gastrinoma. The tumors are generally located in the ZE triangle, which is between the porta hepatis, the mid-duodenum, and the head of the pancreas. Most of the gastrinomas are sporadic, but about 20% are associated with MEN1. So you really should be testing patients for this syndrome if you see a gastrinoma. Generally, the fasting serum gastrin level is going to be greater than 1,000. Okay? And it's inappropriately high, right? Because when you have a lot of acid in the stomach, it should be feedback inhibiting gastrin production, but that's not what's happening here because the gastrin is autonomous from this tumor. And as I mentioned before, you can see moderately increased gastrin use and PPI use and even atrophic gastritis with like pernicious anemia, but generally it's not quite as high as in a gastrinoma. So the workup would include a secretin stimulation test. So what happens here is that you see a marked rise in gastrin when you administer secretin to the patient. This would suggest ZE. You could also do a CT, MRI, or EUS, and even an octreotide scan to localize the tumor. Treatment is mainly surgical and high-dose PPI to control the acid production in the stomach until the tumor is removed. Switching gears a little bit and talking about gastric neoplasia. So neoplasia would really encompass four main tumors of the stomach. So there'd be adenocarcinoma, lymphoma, carcinoids, and GISTs. GISTs are mesenchymal tumors, and the tip-off that you're dealing with a GIST is that it's CD117 positive on biopsies. So that's one of these key tumor markers in GI that's good to memorize. For adenocarcinoma specifically, there are a number of risk factors. There's H. pylori, chronic atrophic gastritis, so pernicious anemia patients have an increased risk of adenocarcinoma. Smoking, alcohol, nitrate, nitrites, Menetrier's disease, which is a syndrome of enlarged gastric folds, and then importantly, genetic conditions. So Lynch syndrome, familial adenomatous polyposis, these are risk factors for gastric cancer. There is a diffuse subtype that's really equal to Leonidas plastica. So that's kind of like that leather bottleneck stomach that you've heard about in medical school. So that's kind of a diffuse infiltration of the folds with cancer. And typically you'll see signet ring cells. And this is usually associated with hereditary gastric cancer, which is associated with an E-cadherin mutation. This is something you may see in a patient or on a test. So acanthosis nigricans, these dark velvety patches on the skin, in this case under the arms. This could be sporadic, but it could also be a tip-off that there's an underlying malignancy present in the patient. And the most typical cancer would be gastric cancer. So gastric adenocarcinoma in terms of staging, so there's the typical TNM classification. Usually we do staging with CT scan and EUS. Unfortunately, less than 10% are found early because they are largely asymptomatic. Sometimes when they are found early, they would be T1N0, M0, so that means they're confined to the mucosa, the submucosa with no lymph nodes and no metastases. And these could actually be cured sometimes endoscopically as opposed to surgically. The 5-year survival when caught this early could be up to 90%, but unfortunately most of the time we find these late, and the 5-year survival could be as low as 3%. Generally, you're going to do treatment with removal of the cancer in the lymph nodes and adjuvant chemo radiation. And again, sometimes if the tumor is very, very small, not ulcerated, we may be able to do endoscopic mucosal resection and cure it that way. Gastric carcinoids, another type of gastric neoplasia. These are actually becoming more common, or we're more commonly seeing them at least, perhaps because we're doing better endoscopy. But they are rare they used to be thought to be rare, and they're often in the setting of chronic hypergastronemic states. There are 3 types of gastric carcinoids, and I guess unfortunately you have to know this. There's type 1, which is associated with pernicious anemia. There's type 2, which is associated with Zollinger-Ellison syndrome. And then there's type 3, which is spontaneous. The key here is that the spontaneous one is the most aggressive and has a high rate of metastases. And also the type 3 one is associated with a normal gastrin level, whereas type 1 and 2 are associated with high gastrin levels. So if there's a question on the test asking about type 3 carcinoids, normal gastrin and aggressive compared to the types 1 and 2. Do you want to talk a little bit about some of the post-gastrectomy syndromes that we may see if patients go to surgery? Fortunately, surgery is less common now because of all the good medicine and endoscopy we have, but there are really 3 main types that you may see in clinical practice. So there's dumping syndrome, blind loop syndrome, and afferent loop syndrome. So dumping syndrome after gastric surgery. So the symptoms associated with this are palpitations, sweating, diarrhea, nausea, and lightheadedness. And there's really two main stages to this. There's an early dumping syndrome, which occurs about 30 minutes after eating. And this is due to hyperosmolality of foods with fluid shifts occurring as the food bolus passes through the surgical site. And then there's a late type that occurs about 90 minutes later, and this is due to hypoglycemia from insulin release when the food finally reaches the small bowel. Treatment for both types is really dietary, so you want to avoid sweets and lactose-containing foods. Try and kind of minimize the volume of food you're taking in, either with smaller meals or less liquids with meals, and then eating meals high in protein and complex carbs. There's something called blind loop syndrome, and what this is you may have a area of bowel that's kind of out of continuity with everything else. For example, like a small bowel diverticula, and you could get bacterial overgrowth in that area, and the bowel contents are kind of not moving through it normally. So you could kind of get distension and pressure in that area, and that could lead to symptoms in the patient. And if there's bacteria overgrowth, it will frequently lead to fat and B12 malabsorption. So bacteria could damage enterocytes, which leads to malabsorption, and bacteria could also compete with the host for B12, so you may see a low B12 level. So generally, the treatment is antibiotics for the presumed bacterial overgrowth that's overcoming this, that's associated with this, and also surgical correction of the issue. So if you have a gigantic jejunal diverticulum, you may want to resect that surgically. And then finally, there's afferent loop syndrome. So in this case, what happens is you get small bowel contents that are trapped in what's called the afferent loop after surgery. So the afferent loop is, and I have a picture of this. Maybe I'll skip to the picture. This is the afferent loop. So here is the stomach. Here is the liver and the biliary tree. And then this is what's called the afferent loop. It's kind of going towards the stomach. And then this is the efferent loop, taking food that's now mixed with bile away from the stomach. And in afferent loop syndrome, you get contents that are trapped here. And that could lead to distension. Eventually it'll lead to vomiting, and then all the contents will kind of get pushed up here and vomited out. So that is afferent loop syndrome. And generally, patients will complain of abdominal bloating 20 minutes to 1 hour after eating, and it's often relieved by vomiting. But again, these are less frequently seen now because surgery is less common gastric surgery is less common in general. So gastroparesis, a word on this. This is pretty common. Delayed gastric emptying typically presents as nausea and vomiting, sometimes early satiety and abdominal pain. So this is classically seen in diabetics. So remember, acute hyperglycemia could delay gastric emptying, but chronic hyperglycemia will damage nerves. So there are really two mechanisms for that. Gastroparesis is not just seen in diabetics, however. It could be seen in scleroderma and even viral infections. So some people get a post-viral gastroparesis that could go on for months to years, and they don't have diabetes. Obviously, you need to rule out obstruction, make sure there's nothing at the pylorus that's blocking things. And then the classic treatment for this would be Reglan. But you have to be careful because of tardive dyskinesia, which I'm sure everybody knows about. So there's a black box warning for that. So here's the Pearl slide for the stomach. Again, hoping you could review this a day or two before the test. Dyspepsia is a non-specific term, right? Epigastric pain radiating to the back and progressive dysphagia with weight loss are among symptoms that would prompt further testing. PPIs could cause false negatives when you're testing for H. pylori. Aspirin and NSAIDs take the benefit away from COX in terms of ulcer risk. GI bleeding from a clean-based ulcer, very low rate of rebleeding, discharge home. Zollinger-Ellison syndrome, inappropriately high gastrin levels. So the pH is low, but the gastrin is high. Gastric carcinoids, type 3. Remember, there's 1, 2, and 3. 3 is the aggressive one. That could be associated with metastases, and it's not associated with a high gastrin level. All right, so now we're moving right along here, switching gears to inflammatory bowel disease. So Crohn's disease and ulcerative colitis, although a small percentage of people can have indeterminate colitis with features of both. This is a table which compares, this is a good review table that compares some of the features of Crohn's disease versus ulcerative colitis. So for Crohn's disease, you're going to see skip areas and deep ulcers, whereas in ulcerative colitis, it's really continuous inflammation with more superficial ulcers. Clinical course, a lot of time Crohn's is more indolent and ulcerative colitis is more acute, meaning that people present quickly with diarrhea and blood in their stool. Granulomas are pathognomonic for Crohn's disease, but unfortunately not always seen. Granulomas are not seen in ulcerative colitis. The rectum is not always involved in Crohn's disease, but it is always involved in ulcerative colitis. Perianal disease is typical in Crohn's disease, so abscesses and fistulas, whereas this is not seen in ulcerative colitis. And small bowel involvement is seen in the majority of cases of Crohn's disease, but it's almost never seen in ulcerative colitis. There is something called backwash ileitis, where if you're doing a colonoscopy and you get into the cecum and then you go up into the TI, you may see a little bit of inflammation in the TI. That's called backwash ileitis, but it's really not clinically significant. Question 10. A 25-year-old male has a 3-year history of abdominal pain and irregular bowel movements. He was diagnosed with Crohn's disease 2 years ago and started on mesalamine. He seemed to respond at first, and now he presents with weight loss and drainage of stool and mucus from around the anus. So physical exam, he has fullness in the right lower quadrant and a fistula near the anus. He's anemic, his albumin is low, and his CRP is elevated. Colonoscopy reveals ulceration of the ileum, ascending colon, and sigmoid, and the biopsies show chronic and active inflammation. There is no abscess on MRI. Which of the following do you recommend? Change mesalamine to sulfasalazine, start the patient on budesonide, start ciprofloxacin, or start infliximab for induction and maintenance. All right, great. Most people got this. I could see why some people might say budesonide. The best choice, though, would be infliximab because the patient's very sick. The albumin's low, the CRP is high, there's active ulceration in the colon. Budesonide may be able to kind of get you a few weeks or months, but the real major improvement would come with infliximab. Changing to sulfasalazine, that's similar to mesalamine that he's already on, so that's not going to help. And then antibiotics are not really going to help in this case. Although ciprofloxacin can have some activity in Crohn's disease. So common drugs for IBD. So 5-ASA agents, these could be used in mild to moderate UC or mild colonic Crohn's disease. So they have a topical anti-inflammatory effect, and they're more effective for UC than Crohn's disease. So mesalamine, I'm sure you see these in clinical practice all the time. There are several different formulations that allow release in different parts of the GI tract. So for example, there is delayed release, such as Asacol and Lialda, that are released in the colon. And then there's Pentasa that could be released in the small bowel and the colon as well. So this may potentially be used in Crohn's disease. Then there's sulfasalazine, which is split by bacteria in the colon into a 5-ASA moiety and a sulfapyridine. Because it's split in the colon, it's not effective for small bowel disease, so it only treats colon disease. Importantly, the sulfapyridine is responsible for reversible infertility in men, leukopenia, and headaches, so this would be a tip-off on a test. If you saw this, you'd be worried about sulfasalazine. Other common drugs would be steroids. These could be used for UC or Crohn's disease, so prednisone and IV steroids would be commonly used. Budesonide, that was one of the potential answers to the prior question. These are enteric-coated, and they're released mainly in the ileum and ascending colon. But we do have this new medication, budesonide medication called Uceris, that could actually be released in the colon and could be used for mild to moderate ulcerative colitis. Enterocort would be a formulation that's more typically used in Crohn's because it's released in the terminal ileum and right colon. Importantly, budesonide has something called a first-pass effect in the liver, meaning that it has fewer systemic side effects than traditional prednisone or steroids, but it still can cause bone density loss and some other side effects similar to steroids, so you do have to be careful with it. Biologics, these are being used more and more frequently in ulcerative colitis and Crohn's disease. So these are medications that include monoclonal antibodies to TNF-alpha and some other ones, including antibodies to integrin. So these play a role in modulating the immune system. Generally, they're used for moderate to severe Crohn's disease, like in the patient in our question. It could be used for fistulizing disease in Crohn's and also for refractory ulcerative colitis. Generally, because these are immunosuppressive medicines, you want to make sure the patient doesn't have latent TB or hepatitis B, and you want to administer all recommended age-appropriate vaccinations, ideally before beginning therapy. So some of the classic ones you may see would be infliximab, adalimumab, or also known as Humira or Amgen. And then there's vedolizumab or Entyvio, which is an antibody to integrin. So all three of these could be used in both UC and Crohn's disease. There are probably 5 or 6 others that are floating around out there as well. I can't even remember all of them. There's so many. Then there are the immunomodulators. So this would include 6-mercaptopurine or azathioprine. These could be used concurrently with anti-TNF therapies. So 6-MP and azathioprine, just like the biologics that we discussed, are steroid sparing, meaning that if a person's on prednisone and you put them on a biologic or either 6-MP or azathioprine, you could taper the steroids off. It's important to monitor CBC and liver tests when patients are on 6-MP or azathioprine because there are metabolites that could affect the bone marrow or can be hepatotoxic. So the metabolite that's bone marrow suppressive is 6-TG, and 6-MMP is the metabolite that's hepatotoxic. We actually have panels where we could easily order these metabolites. So if you have somebody on one of these medications and their liver tests shoot up, or the white blood cell count drops, then you could order the metabolites to see what you're dealing with. There's methotrexate is another medicine used in inflammatory bowel disease. This is a toxic folic acid analog, and it's used specifically in Crohn's disease, not ulcerative colitis. Its long-term use is associated with hepatotoxicity, and it's strictly contraindicated in pregnancy. And then there's cyclosporin, which is fast-acting for refractory or severe ulcerative colitis. So remember, methotrexate Crohn's disease, cyclosporin UC. Otherwise, a lot of the other medicines could be used in both UC and Crohn's, depending on the clinical scenario. So just to hone in a little bit and talk more about Crohn's disease, there's typically a bimodal onset. So there's really a first peak in incidence in patients in their 20s and 30s and a second smaller peak for patients in the 70s and 80s. The inflammation is transmural, so it involves the entire wall. That's a good way to remember why you get fistulas and abscesses, because the entire wall is involved. Endoscopy will show deep ulcers and potentially granulomas, which are pathognomonic, but granulomas are not always seen. The tetrad to remember is rectal sparing is often seen in contrast to ulcerative colitis, which always involves the rectum. You'll see skip lesions, perianal disease, and ileocecal involvement. This is an X-ray of a small bowel follow-through. So you could see here that the Small bowel is kind of narrowed and it's kind of tethered to each other, so that would be typical of Crohn's disease. And generally, traditionally, it's been felt that you'll see colon disease only in about 30%, small bowel disease alone in 30%, and both small bowel and colonic disease in about 40% of cases of patients with Crohn's disease. There's something called the Crohn's Disease Assessment of Disease Activity, or the CDAI. This is just a standardized way that we could kind of communicate between one another with regards to patient symptoms and severity and when to, thresholds of when to start medicine. I don't think it's really important to know all the details of this, except to know that there are a variety of factors that come into play here to calculate it, including number of stools per day, abdominal pain, general well-being, complications, etc. And generally, if you're under 150, you're considered to be in remission. There is a newer focus now on what's called deep remission. So that means that not only does the patient have no symptoms, but if you go in and do an endoscopy, there's no disease, either grossly to the naked eye or microscopically. So what we're really aiming for now with all these new medicines, these biologics, is deep remission. Because even if the patient has no symptoms, but they have disease in their colon, even microscopically, it's a risk factor for recurrence and bad outcomes going forward. So the aim is for deep remission. Complications of Crohn's disease, we've already talked about some of these: fistulas and abscesses due to the transmural inflammation. Key issues are osteoporosis due to vitamin D malabsorption, so you want to be monitoring this continuously. You could get B12 deficiency, especially if the patient has had surgery of the terminal ileum. Importantly, there is a risk of colon cancer in Crohn's disease, not just ulcerative colitis. So generally, if a person has Crohn's disease involving the colon and about more than 30% is affected, that is a risk factor for dysplasia and colon cancer. The guidelines are kind of frequently changing with regards to this, but I tried to distill it down for you. So generally, if you've had about 8 years of disease, or really 8 years after symptom onset, you're going to want to screen those patients for dysplasia in the hopes of preventing IBD-associated cancer. Another complication would be toxic megacolon. This could be seen in Crohn's disease or ulcerative colitis. So basically what you get is just a colonic dilatation, usually of the transverse colon, and you could get perforation, sepsis, could be a real nightmare. Here's a slide regarding extraintestinal manifestations of IBD. Generally, all of these can be seen in either ulcerative colitis or Crohn's disease, but some are more common in one versus the other, so I've kind of noted that in some of the slides. So the important distinction here is whether these manifestations improve as disease activity improves, or if these extraintestinal manifestations kind of go on their own without improvement with the underlying IBD. So examples of conditions that improve with disease activity would be RF negative type 1 arthritis, so that's kind of like the larger joints. Aphthous ulcers of the mouth, erythema nodosum, I have slides on this, I'll show you this. Pyoderma gangrenosum in some cases. Associated conditions that will not improve would include ankylosing spondylitis, which is associated with some patients with IBD, iritis, scleritis, uveitis, PSC, which we'll talk about in more detail, and RF negative arthritis, which is the small joint polyarticular arthritis. So here's a slide showing pyoderma gangrenosum. This is really an unfortunate condition. It's characterized by pathergy, which means deep ulcers developing at sites of minor trauma. It could be seen in ulcerative colitis or Crohn's disease, but typically it's more common in ulcerative colitis. And then here's erythema nodosum. So you get like these tender red nodules, generally on the shins or extensor surfaces. And this could be seen in ulcerative colitis or Crohn's disease. Question number 11. A patient with Crohn's disease was doing poorly on mesalamine, and a change to a more aggressive therapy, biologic or 6-MP, as planned. She's been on high-dose steroids for 2 months. Which of the following should be done now? TB test, begin to taper off steroids, assess for hepatitis B, vaccinate if negative, D, all of the above. Great, pretty much everyone got that. So all these things are fair game, right? You want to make sure the patient doesn't have TB, You don't want people on long-term steroids because of the horrible side effects, so you want to use steroid-sparing agents like 6-MP or azathioprine or a biologic to get them off the steroids. And then obviously you want to assess for hepatitis B and vaccinate if negative, because they could have a terrible recurrence of hepatitis B if they have kind of smoldering hep B that no one's aware of. So it's all of the above. We already talked about some of the general treatments for IBD. I'll kind of focus a little bit on Crohn's disease specifically. So 5-ASAs are rarely used in Crohn's disease, but you can sometimes use sulfasalazine in mild to moderate chronic disease. And I also mentioned in the other slide that there are some mesalamine preparations such as Pentasa that could be used for small bowel disease. Prednisone is often used, but again, we don't want to use this long-term due to the horrific side effects. Budesonide could be used for mild to moderate Crohn's disease, but could generally be used just for a few months. So really, most of these patients are put on either 6-MP or azathioprine plus or minus biologics, or even biologics alone. Both of these medicine types are steroid sparing, meaning that if they're on prednisone, we could generally taper that off over the course of weeks to months. It should be noted that there are significantly increased risks of lymphoma and skin cancer with 6-MP or azathioprine. And the combo therapy of 6-MP or azathioprine in conjunction with a biologic is associated with an increased risk of hepatosplenic T-cell lymphoma, particularly in younger men. So there are studies that showed that. And as we already went over in the question, you want to screen patients for Hep B and TB before starting any of these immunosuppressive agents. Some treatment scenarios that you may see in clinical practice are on a test. So if there's acute small bowel obstruction or a flare, you may want to start the patient on steroids, IV steroids potentially, but again, you don't want to leave them on that long term. If the patient has fistula or perianal disease, 6-MP azathioprine or biologics could work, as can certain types of antibiotics like Cipro or Flagyl. If the patient has steroid-dependent or moderate to severe disease, you really want to put them on a biologic plus minus 6-MP azathioprine, because these are steroid-sparing agents, and the goal is to get the steroids off. And then you have to make the distinction between induction of remission and maintenance. So induction means the patient has acute symptoms and you want to get those under control, and maintenance is you have a patient that you want to maintain on a long-term safe medicine. So for induction of remission, you would generally start with a biologic plus minus 6-MP azathioprine. 6-MP azathioprine alone is not good for induction of remission. And the reason for that is it takes weeks to months for those drugs to kick in. So that is not going to work. You can, 6-MP azathioprine are more for long-term treatment, not in the acute setting. For maintenance of remission, you'll have a patient on a biologic, possibly with 6-MP azathioprine as well. With regards to surgery and recurrence in Crohn's disease, because of all these new medicines that we have, fortunately surgical needs are decreasing. But if you do have surgery, the most common site would be in the ileocolonic area. Surgery may be needed for obstruction, perforation, abscesses, or cancer. And we do want to assess for the risk factors for postoperative recurrence after a patient has surgery, because you may want to put those patients on prophylactic medications to prevent future return of the disease. So some risk factors for postoperative recurrence, I think this is fair game and important points for a test, would be penetrating disease, such as fistulizing disease, more extensive small bowel involvement, prior surgery for Crohn's disease, smoking, which will worsen the course of Crohn's disease. All Crohn's disease patients should be encouraged to stop smoking, a shorter pre-op disease duration, and younger patients. And so a lot of times after a patient has had surgery, about 6 months later, we'll go in with a colonoscope and we'll assess the anastomotic site, and we'll kind of use that information in conjunction with these risk factors to make a determination of whether or not we're going to put them on prophylactic medicines to prevent future recurrence. So question 12. A 30-year-old female has ulcerative colitis for about 10 years. 5 years ago, azathioprine was added to her daily mesalamine after she had several flares requiring prednisone. With the current combination, she has been in clinical remission. She presents now with persistent watery diarrhea. There is no blood or abdominal pain. There's no history of recent antibiotic use. There is mild diffuse abdominal tenderness. The white count is a little bit elevated and the patient is a little bit anemic. Which of the following do you recommend? Empiric prednisone, colonoscopy, stool for C. diff, no treatment because we think it's just viral, start infliximab for refractory UC. Great, most people got this. So anytime a patient has a sudden change in their symptoms with diarrhea, you want to make sure that they don't have C. diff. It did say in the question that the patient didn't have recent antibiotic use, but that you can't rely on that. So patients could get C. diff without prior antibiotic use. So the answer is C. diff. C. diff is associated with way worse outcomes in patients with IBD, so it's critical that we make that diagnosis. Shifting gears now, talking about ulcerative colitis. So here we've already discussed this. Inflammation begins in the rectum and extends proximally in a contiguous fashion. Remember, Crohn's disease, there's skip areas. It's confined to the colon except for rare cases of backwash ileitis. Again, we discussed this. 70 to 80% of UC patients are P-ANCA positive, and the main symptoms are abdominal pain and bloody diarrhea. Just like Crohn's disease, it's always important to rule out infectious causes. So C. diff, critical to rule this out. Campylobacter could actually mimic ulcerative colitis because you could get relapsing Campylobacter over time, over weeks to months, and it could actually resemble ulcerative colitis. Entamoeba histolytica would be another organism that can mimic ulcerative colitis. And again, consider C. diff infection whenever an IBD patient presents with a flare, because if you miss it, it could lead to way worse outcomes. Similar to the Crohn's disease activity index, there's another tool to assess disease activity in ulcerative colitis. It's called the Mayo score. It's here if you want to see it. It's kind of similar to the CDAI, but it's a way to standardize how we determine treatment thresholds in different ulcerative colitis patients. So cancer in ulcerative colitis, again, like in Crohn's disease, there's definitely a risk of dysplasia and cancer. The risk of colon cancer increases with these key points. Duration of disease, increased duration will lead to a higher risk of dysplasia. Pancolitis, higher risk of dysplasia. Active inflammation, and PSC. So PSC is a major risk factor for colon cancer in people with ulcerative colitis. Again, the guidelines kind of vary depending on society. I tried to distill it down for you. So generally you start about 8 to 10 years after diagnosis, or really after symptom development, because the symptoms really are kind of determine when the patient first had active inflammation. And generally you're going to do this if the patient has at least left-sided colitis, and obviously if there's pancolitis as well. Follow-up intervals vary based on society and findings on colonoscopy, but can range from 1 to 3 years. I'd advise you to consult with a gastroenterologist. These patients should be under care of a gastroenterologist to determine the exact intervals. For ulcerative colitis treatment, so mild to moderate disease treatment options include rectal 5-ASAs. So these could be enemas or suppositories. These are mainly going to treat proctitis. Sometimes you could use rectal steroids as a second line. If the distal disease, like sigmoid and rectal disease, is not really responding to enemas or suppositories, you could add oral mesalamine like Asacol or Lialda, and the combo therapy is actually more effective than either alone. And then obviously if you have more proximal disease, you're going to need an oral agent because the suppositories and enemas are not going to reach proximally. If there's moderate to severe disease present, initial therapy may involve oral prednisone as an outpatient or potentially inpatient therapy with IV steroids, possibly IV infliximab or IV cyclosporin. Remember I said in the prior slides, cyclosporin is specifically for ulcerative colitis, methotrexate is for Crohn's disease. If it's fulminant, the patient may even need a colectomy, particularly if there's a poor response to medicine. Maintenance therapy after remission for severe disease generally is going to involve a 6-MP azathioprine or biologics, both of which are steroid sparing. So this is fairly similar to Crohn's disease. There are some newer biologics available. So there's vedolizumab, which is an antibody to integrin as opposed to an anti-TNF antibody, which would be something like infliximab. This could be used if there's a primary failure to an anti-TF like infliximab. So you put the patient on an infliximab and they don't respond at all. You could try using vedolizumab. Or if there's a secondary failure. So some people are on infliximab for a long period of time. They develop antibodies to infliximab. And you may need to change them to a different class of medications. So that would be secondary failure. So kind of switching back to the surveillance and surgical indications. So we talked about when we need to do surveillance. But what about surgical indications? So if you have polypoid dysplastic mucosa on your surveillance colonoscopy, A lot of times we could actually take these out endoscopically with a snare or argon plasma coagulation. There are a variety of modalities we could use to get these lesions out, but surgery is sometimes needed depending on the size of the lesion and how it looks under the microscope. A lot of times these patients will be referred to an IBD specialist. Of concern is something called flat or invisible dysplasia. So when you do surveillance, you're not only looking for gross abnormalities to the naked eye, but you're also taking random biopsies in normal appearing mucosa. And if you get dysplasia in one of these random biopsies, that could be more difficult to manage because you may not know exactly where it is. And sometimes those patients may need surgery, particularly after they've seen an IBD specialist. Sometimes they have to undergo chromoendoscopy, which is where you kind of stain the colonic mucosa to try and see if you can actually see a specific lesion. But ultimately, some of these patients may require surgery. Non-cancer indications for surgery include intractable disease, toxic megacolon, perforation, hemorrhage. These are pretty intuitive. So a word on ulcerative colitis and PSC. So you should suspect PSC in any UC patient with jaundice, itching, or cholestatic LFTs, or even an isolated elevation in the ALK-Phos. So 5% of UC patients will eventually develop PSC in their lifetimes. PSC could also be seen in Crohn's disease patients, but it's a little bit less frequent. Generally, the best test would be an MRCP because that could really get a good look at the bile ducts. And these patients have a risk of both colon cancer and cholangiocarcinoma. So this is another potential question. I don't know the answers. I don't know what questions they put on this test, but there could be a question that says, okay, a patient has had ulcerative colitis for 1 year. You diagnose them with PSC. When do you start colon cancer surveillance? The answer is right away because the colon cancer risk is so high in PSC that you have to start immediately. You don't wait 8 to 10 years. So here is an ERCP showing PSC. So this is the biliary tree, the common hepatic duct, common bile duct, and here you could see the biliary tree. And you could see here that these biliary branches are narrowed with kind of a bead-like appearance. So these are multifocal strictures that are forming a string of pearl sign. So if you saw this, this would be very classic for PSC. So IBD pearls, we finished the IBD section. UC, contiguous inflammation starting in the rectum. Crohn's disease, skip lesions, granulomas, transmural inflammation, which is why you get fistulas and abscesses in contrast to UC. Biologics and azathioprine and 6-MP are steroid sparing, which is why they're so important in clinical practice. You need to rule out C. diff in any IBD flare. The risk of colon cancer increases with duration of disease, pancolitis, active inflammation, and PSC. Elevated liver tests and IBD, rule out PSC. Start surveillance colonoscopy at the time of PSC diagnosis. So I think these are some of the key points from the prior slides. So diarrhea. So generally this is defined as greater than 200 to 250 grams per day of stool, where the normal is 150 to 180. Normal stool frequency could actually vary from 3 times a day to 3 times a week. So you really have to know what your patient's baseline is to determine if there's an abnormality. General divisions are acute diarrhea less than 2 weeks, persistent 2 to 4 weeks, and chronic greater than 4 weeks. Acute diarrhea specifically, it's often infectious, so you have to take a good history, including travel, sick contacts, etc. It's important to do a physical exam to assess for signs of dehydration. Generally, you're going to send off stool studies that would include a culture, ovine parasites, C. diff, and fecal white blood cell count. Colonoscopy or sigmoidoscopy is sometimes used because it could help differentiate IBD from an acute infectious etiology. So crypt abscesses could be seen in both infections and IBD, but if you see crypt distortion specifically, it implies that there's chronicity there. So that would be typical for IBD. So crypt distortion or branching means chronicity, IBD, not infection for the most part. When you're talking about chronic diarrhea, you're looking at symptoms for more than a month. There are a number of potential contributing mechanisms that you've probably heard of. There could be osmotic diarrhea, secretory diarrhea, or increased motility. There's the dreaded stool osmolar gap discussion that everyone tries to order this test, and sometimes we just can't get it. So the formula is 290 minus 2 times stool sodium plus stool potassium.
For the 290 above, stool osmolality is assumed to be equal to serum osmolality of 290. Any significant difference is due to unmeasured osmoles. So I have a few more slides on this. So if you see an extremely low stool osmolality on this test, that actually suggests a dilute sample. So it could be fictitious, like somebody is submitting urine instead of stool. If there's secretory diarrhea, the gap is often less than 50. And the reason for that is that sodium and potassium make up a greater percentage of the osmolality compared to osmotic diarrhea. So if you go back to this formula, you'll see that the sodium and potassium are going to be higher. So the difference between this and this is going to be lower, right? So secretory diarrhea, low gap, okay? Osmotic diarrhea, on the other hand, you have unmeasured osmoles that are replacing sodium and potassium, so the gap is going to be higher. So it's often greater than 100. So again, low gap, secretory diarrhea, higher gap, osmotic diarrhea. With that being said, many causes of diarrhea could have both osmotic and secretory components. But some causes of pure secretory diarrhea would be an enterotoxin from a variety of organisms, such as E. coli or staph. Gastrinomas and VIPomas, some more slides on VIPomas coming up. Those could cause secretory diarrhea. Osmotic diarrhea, the key thing about osmotic diarrhea is that a 24-hour fast improves the diarrhea in contrast to the secretory diarrhea. So causes of osmotic diarrhea, where there are unmeasured osmoles in the lumen of the gut, would include lactase deficiency. You're going to see increased lactose in the lumen. Magnesium-containing laxatives, sugar alcohols, malabsorption, so pancreatic insufficiency, celiac disease, and bacterial overgrowth could all be associated with malabsorption, which would lead to unmeasured osmoles in the lumen. And then most laxatives. So if you take these things out of your diet, the osmotic diarrhea is probably going to go away, as opposed to a secretory diarrhea. So if you have an exotoxin there, you fasting is not really going to help anything, and you're going to still have this secretory diarrhea. We'll kind of run through some causes of chronic diarrhea to consider. So these are just kind of flash points that we'll go over. So an AIDS patient with diarrhea and weight loss could be a number of organisms: Cryptosporidium, Entamoeba, Histolytica, Giardia, etc. There's something called AIDS enteropathy, which is an entity that is idiopathic and pathogen negative. It's frequently associated with high volume diarrhea. If there's an AIDS patient with diarrhea and fever, a lot of times you could see Mycobacterium or Campylobacter and a variety of other infections. Obviously, there's going to be some overlap between these two groups. As I mentioned previously, if you see large volume, it could be due to AIDS enteropathy. Diabetes is associated with diarrhea, generally because of visceral autonomic neuropathy. So just the way the bowel is innervated can lead to changes in motility, which may be associated with diarrhea. On the other hand, you can get pancreatic insufficiency in the setting of diabetes, which could lead to malabsorption and diarrhea. So remember, diabetes can cause pancreatic damage, but remember that pancreatic damage could also cause diabetes. So it can kind of work both ways. Diabetes is also associated with bacterial overgrowth, which could lead to enterocyte damage and malabsorption. These are the ways that diabetes could be associated with diarrhea or loose stool. Amyloid, similar to diabetes, could be associated with visceral autonomic neuropathy, again, changing the way the bowel is innervated, which could lead to diarrhea. Keep in mind, though, that amyloid could also be associated with other entities, including gastroparesis and postural hypotension. Carcinoid syndrome, talked a little bit about gastrocarcinoids previously. If the carcinoid metastasizes to the liver, it could release vasoactive mediators into the bloodstream, and that could lead to diarrhea and a variety of other symptoms because these vasoactive mediators can't be deactivated. So carcinoid syndrome is associated with diarrhea, again, when the tumor metastasizes to the liver. So carcinoid syndrome. Most carcinoids are asymptomatic and do not metastasize, fortunately. But if they do, and you have carcinoid syndrome, some of the symptoms would be explosive diarrhea, flushing, crampy abdominal pain, hypotension, and tachycardia. The way to do this is to order a 25 urine 5-HIAA, and you could also order a CT scan, which may show metastases in the liver. Again, the mets to the liver are what is needed to have the vasoactive mediators released into the blood. You could also do an MRI and possibly an octreotide scan So many tumors express somatostatin receptors, and octreotide scans utilize radiolabeled somatostatin, an analog called octreotide. So that's why an octreotide scan would be useful in carcinoid to diagnose carcinoid syndrome. Okay, question 14. A 48-year-old male comes to see you for chronic diarrhea. Symptoms began 2 years ago, and he reports passing 3 to 4 loose stools daily. His norm was previously 1 to 2 solid stools per day. After going online, he's convinced he must have IBD since his neighbor was diagnosed with UC last month. There's no blood in the stool, and there's no weight loss. He does complain of some abdominal discomfort. He goes to see a GI doctor and has a colonoscopy that shows a quote-unquote lymphocytic infiltrate. The colonoscopy report indicates that the mucosa looked normal. Hint. What is the likely diagnosis? Bile acid diarrhea, microscopic colitis, ulcerative colitis, or C. diff? Right, microscopic colitis. So the hint there is that everything looks normal, right? But under the microscope, it shows a lymphocytic infiltrate. So the answer is microscopic colitis. So microscopic colitis, there are 2 subtypes. There's collagenous and lymphocytic. A key and testable point would be that it is associated with celiac disease. So there's a 72-fold increased risk of microscopic colitis in celiac patients and vice versa. So in microscopic colitis, you have normal-looking mucosa when you look at it to the naked eye during colonoscopy, but if you actually take biopsies, it will show either a collagenous band in the submucosa or a lymphocytic infiltrate. The treatment, if mild, can involve antidiarrheals such as loperamide, but if the symptoms are more severe, you may want to consider starting something like budesonide. This is actually a picture of the collagen band here. So you can see this thick pink material here. So this would be the collagenous colitis subtype of microscopic colitis. Other causes of chronic diarrhea to consider would be lactase deficiency. This is a common disorder. IBSD, obviously exceedingly common. Patients generally have loose stools with normal daily volume. I have a few slides on this coming up. And then there's something called bile acid diarrhea, which is becoming more recognized as an entity. So remember that bile acids are produced in the liver and stalled in the gallbladder, and they're released to digest fat in the small bowel. They are normally absorbed back up at the TI, and then they have their enterohepatic circulation. However, they could spill into the colon, and they could actually act as secretagogues, where they will increase fluid secretion from the colon. So bile acid diarrhea is becoming more recognized as a cause of chronic diarrhea, mainly from colonic secretion of fluid. So diarrhea pearls. So remember, stool osmolar gap greater than 50 to 100 is osmotic diarrhea. Stool osmolar gap less than 50, secretory diarrhea. Key point, 24-hour fast improves osmotic diarrhea, but is really not going to improve secretory diarrhea. Carcinoid syndrome specifically occurs if you have mets to the liver, so you're able to release those vasoactive mediators into the blood. Microscopic colitis appears normal during colonoscopy, but abnormal under the microscope. Celiac patients with persistent diarrhea consider concurrent microscopic colitis. Remember, there's a close relationship between celiac disease and microscopic colitis in terms of risk of either, respectively. All right, so we're going to talk about malabsorption. So in malabsorption, patients present with chronic diarrhea and a variety of other manifestations, including elevated INR, iron deficiency, calcium deficiency, low albumin, and others. There are really 2 main categories of malabsorption, or 2 ways to think about it. There's decreased mucosal transport, which could be either due to enterocyte damage or small bowel resection, or there could be decreased digestion, so not enough enzymes, for example, in pancreatic insufficiency. So talking about decreased mucosal transport first, so small bowel diseases would be examples of this, so like celiac, Whipple's, intestinal lymphoma. So focusing in on celiac, affects about 1% of the population. It's an autoimmune intestinal disorder that has an altered response to dietary gluten. and it results in small bowel villus atrophy. So you do need to be aware that small bowel villus atrophy is nonspecific for celiac specifically, and it can be associated with a number of other entities as well. Iron deficiency anemia is the most common sign. Also be aware of osteoporosis and osteomalacia in patients with celiac. And if you see this rash, dermatitis herpetiformis, this is pathognomonic for celiac disease. It's an itchy vesiculopapular eruption that occurs in pretty much anywhere on the body, but typically involves the trunk. So in terms of diagnosis, it may include serologies, for example, the IgA tissue transglutaminase, which has a 90% sensitivity. You do have to check the serum IgA because up to 5% of celiac patients may be IgA deficient, so that could give you a false negative TTG test. If you have an abnormal duodenal biopsy, obviously that is concerning for celiac disease. I should mention that most paths lead to an EGD when you're diagnosing celiac disease. So even if you have positive serologies, generally you're going to want to confirm that with an upper endoscopy. Another key point is that response to a gluten-free diet does not necessarily indicate celiac disease. We have lots of patients coming in that are on a fad gluten-free diet, and they're like, oh, my life is so much better, and they think they have celiac disease. But they may have non-celiac gluten sensitivity, where they have a response to a gluten-free diet, but there's really no celiac disease present. Other causes of malabsorption due to decreased mucosal transport would include collagenous sprue, which is a variant of celiac with large masses of subepithelial eosinophilic hyaline material. Tropical sprue, which is infectious, which is caused by an infectious organism that no one is really sure which agent it is. That's endemic to the Caribbean, South Africa, and other parts of the world. This is generally treated with antibiotics for about 3 to 6 months and with folic acid replacement as well, because folate levels could be low in this condition. And then there's an important entity called olmesartan-associated enteropathy, and this has really been being recognized over the past few years. It's an angiotensin II receptor antagonist, and it causes a sprue-like enteropathy. So before you diagnose people with celiac disease, make sure your patients are not on this medicine. Decreased mucosal transport is also associated with Whipple's disease, which is actually a pretty rare disease, but it's associated with a tetrad of symptoms, including joint pain, abdominal pain, weight loss, and diarrhea with malabsorption. It's caused by T. Whippley, which is a gram-positive bacillus, and it is associated with neurologic symptoms, including dementia and paranoia, and biopsies will classically show foamy macrophages with positive PAS staining of the bacterial remnants. And it's treated with ceftriaxone or penicillin for 14 days, and then trimethylsulfa for about a year. There's also an entity called eosinophilic gastroenteritis, where you get eosinophils that really infiltrate the GI tract. Could be in the stomach, small bowel, and the colon, and it could lead to malabsorption. A lot of times you'll see peripheral eosinophilia, and similar to, it's a different entity than eosinophilic esophagitis, but similar to eosinophilic esophagitis, it could sometimes be treated with an elimination diet, and it often needs to be treated with steroids. So decreased mucosal transport could also be seen as a consequence of generally massive small bowel resection. This could be seen resections could be seen in the setting of ischemia or IBD, like Crohn's disease. So generally, these are important cutoffs to remember. So when less than 100 centimeters of the terminal ileum is resected, you could get bile acid diarrhea. So what happens here is bile acids are not absorbed in the TI and they overflow in the colon. And I mentioned this previously, they could cause colonic secretion because they're colonic secretagogues. However, if you have greater than 100 centimeters of the TI resected, bile acids are depleted. Okay, and then this leads to malabsorption and steatorrhea because bile acids are needed for fat digestion. Also, when greater than 100 centimeters of the TI is resected, you will get calcium oxalate kidney stones. And the reason for this is because fatty acids bind calcium in the lumen so that oxalate is freed up and it's absorbed and it can deposit in the kidney. You could also get gallstones, usually pigmented gallstones, in the setting of decreased mucosal transport from small bowel resection. And the reason is because you get altered balance of bile acids and cholesterol that make up gallstones. And then you could get a variety of vitamins that are malabsorbed, including vitamin D, which could lead to hypoglycemia and bone disease. So there's something called short bowel resection, which in contrast to what I was just discussing previously, really is when there's almost no small bowel left. Okay. Before we were talking about, more than 100 centimeters versus less than 100 centimeters of the TI remaining. But here we're talking about almost all of the small bowel being taken out. So you're generally going to see short gut syndrome if you have less than 60 centimeters of remaining small bowel. However, even if you have 100 centimeters of small bowel left, you could actually have short gut syndrome if your ileocecal valve is removed at the same time. And the reason for that is that the ileocecal valve, if the ileocecal valve is gone, it could allow bacteria to go from the colon into the small bowel, which could lead to small bowel bacterial overgrowth, and it could exacerbate symptoms of short gut. A key point is that leaving the colon in actually helps tremendously because the colon could absorb water, electrolytes, and short-chain fatty acids. So if you have a small bowel resection, but you have your colon in, you may be able to tolerate the situation better than if your colon was taken out. Generally, for short bowel syndrome, you're going to want to treat the patient with the diet will consist of a low-fat diet, small frequent meals, and vitamin supplementation. So now we're going to switch gears and talk about decreased digestion as a cause of malabsorption. So really, there are two main causes. One is pancreatic insufficiency, and the other is bile acid deficiency. So pancreatic insufficiency, for example, could be seen in chronic pancreatitis. So these patients will have a positive response to treatment with pancreatic enzymes, and it's important to note that you should always think of pancreatic cancer in these settings because this obviously needs to be ruled out before you could assume that someone just has chronic pancreatitis. Bile acid deficiency, as I mentioned, bile acids are needed for fat digestion and enabling nutrient absorption. So you could see bile acid deficiency if you've had greater than 100 centimeters of your ileum removed, which I mentioned previously. You start losing the bile acids in your body. You could develop bile acid deficiency in the setting of severe liver disease because of decreased production of bile acids. Zollinger-Ellison syndrome, the high acid levels could actually cause bile acids to precipitate. And in small bowel bacterial overgrowth, you could get breakdown of bile acids, and the bacteria could also damage enterocytes and lead to malabsorption. So again, the two main causes of malabsorption due to decreased digestion, pancreatic insufficiency and bile acid deficiency. When we focus in on small bowel bacterial overgrowth specifically, the presenting complaint is usually abdominal distension and steatorrhea. A key point is that intestinal bacteria can make folate, but they block absorption of B12. So if you're looking on lab results, like on a test question, and you see high folate levels and low B12 levels, that is a tip-off that there's small bowel bacterial overgrowth present. Potential causes include structural abnormalities. As I mentioned, if the ICV is removed, you could get bacteria that go up into the small bowel. Motility disorders, like in the setting of diabetes, achlorhydria in the setting of pernicious anemia, etc. So tests for bacterial overgrowth specifically, you could do something called a lactulose hydrogen breath test. So basically what you do here is you give PO lactulose to the patient, and then you measure hydrogen in the breath because bacteria produce hydrogen from lactulose. You can consider treatment with various antibiotics. Rifaximin is something that we frequently use, and that is frequently helpful for patients. Other tests for malabsorption would be tests specifically for steatorrhea. So you could do a fecal fat test. So the gold standard is a 72-hour quantitative fecal fat, but sometimes that's hard to do in clinical practice. You can do a Sudan stain, which is kind of a spot screen for fecal fat. And keep in mind that any patient who has greater than 40 grams per day of fecal fat likely has pancreatic insufficiency unless there's a history of massive intestinal resection, because generally the really high fat content in the stool is seen with those two entities, pancreatic insufficiency or massive intestinal resection. There's another test called the D-xylose absorption test. And what this does is it measures the absorptive capacity of the small bowel. So the patient ingests D-xylose orally, and then you measure its excretion in the urine, and also you can measure levels in the blood. And it allows you to exclude some small bowel disease. Because what happens is that if the small bowel mucosa is diseased, you may not be able to absorb D-xylose, whereas if the small bowel mucosa is normal, you will be able to. So that's really the key distinction for this test. So if you have a normal D-xylose test, the bottom line is that you have you're going to have normal small bowel mucosa. So some malabsorption pearls. Celiac disease is an example of decreased mucosal transport and is associated with dermatitis herpetiformis. That rash is pathognomonic for celiac disease. You're going to have bile acid diarrhea if you have less than 100 centimeters of the TI resected. Remember, the bile acids will go into the colon and act as secretagogues. However, if you resect more than 100 centimeters of the ileum, you will lose bile acids, so your body stores will be depleted. Because bile acids help digest fat, you're going to get fatty, and they're no longer present in sufficient quantities, you're going to get fatty acid diarrhea. The two main causes of decreased digestion are pancreatic insufficiency and bile acid deficiency. And small bowel overgrowth can be actually associated with two different mechanisms: decreased transport and decreased digestion. And the main test for small intestinal bacterial overgrowth is the lactulose breath test. And remember, if you see on a test high folate levels and low B12 levels, that is a tip-off that bacterial overgrowth is present. All right, so now we're going to switch gears and talk about constipation. So the majority of constipation causes are idiopathic, but you definitely need to be on the lookout for colonic inertia or slow transit constipation and pelvic floor dysfunction. You also should be looking very carefully at the medicines that your patients are on. So anticholinergic drugs are a big culprit for causing constipation, as are opioid narcotic pain medicines. Even iron and calcium supplementations and calcium channel blockers can cause constipation. And then there's endocrine etiologies, including diabetes and hypothyroidism. And finally, pregnancy due to altered progesterone and estrogen levels can be associated with constipation. There could also be neurologic causes of constipation. For example, if there's damage or disease involving the parasympathetics. So you could have sacral nerve damage, MS, Chagas disease. In this infection, it could lead to alterations of the enteric nervous system, of the nerve supplying the gut, which could lead to constipation. And then there's Hirschsprung's disease, which is aganglionic megacolon. So what happens is the internal anal sphincter does not have the proper nerve supply, and it won't relax with rectal distension. And so that could lead to basically a backup at the anal sphincter, and the patients are straining, and could be very uncomfortable, and it's seen mainly in the pediatric population, but could also be seen in adults. And then there's pelvic floor dysfunction. So in this condition, which is actually pretty common and probably under-recognized, patients are unable to properly relax muscles during defecation. So normally, when you're going to have a bowel movement, you relax the puborectalis muscle and the external anal sphincter, and you get pelvic floor descent. In pelvic floor dysfunction, these processes do not occur. There's some take-home points from the American Gastroenterological Association on constipation. These guidelines came out a few years ago, and they basically divide constipation into three categories: normal transit, slow transit, and disorders of defecation. In general, the move now is to rule out a problem with defecation before considering these other kinds of constipation, like slow transit constipation. So the disorders of defecation would include disorders with increased resistance to evacuation, so that would be pelvic floor dysfunction. So again, the push now is to rule these things out first before you start considering these other entities like slow transit constipation. So with regards to diagnosis, if the patient has concerning symptoms or signs, weight loss, rectal bleeding, anemia, a family history of colorectal cancer, or recent onset without explanation, or no recent screening, you're generally going to want to send that patient for a colonoscopy to make sure that there's no cancer present. You're also going to want to check a serum calcium and a TSH level. Other tests that you're frequently going to see being used for constipation would include anal rectal manometry. So in this test, you could actually measure the sphincter pressures, you can measure the rectal sensation, and you can measure rectal compliance. There's also a defecogram, which is a barium X-ray, where the patient goes to the bathroom and you could actually see how the barium is pooling in certain areas. That's frequently a good test to look for anatomical problems like rectoceles. And then there's the SITS marker study, which is this it's a capsule that people ingest, and it has about 24 markers in it. And the markers show up on an X-ray, so you could see where they collect in the colon. So if someone takes the SITS marker pill and then a few days later you do an X-ray and there's nothing there, great, everything's being expelled. But if they're collecting in certain areas, it could kind of give you a hint as to what's going on. So if you see SITS markers that are delayed in the left and or right colon, it could be indicative of slow transit constipation. If they're all collecting distally in the rectum, then that's probably more indicative of something like pelvic floor dysfunction. And then the defecogram can indicate presence of prolapsed rectoceles, intussusception, mainly anatomical things that we discussed previously. Treatment. One of the key things is that people are not getting enough fiber in the diets. Generally, you want people to get about at least 25 to 30 grams of fiber, and you want them to drink adequate water. If you really start delving into people's histories, most people are not getting that amount of fiber. And a lot of times if you counsel them on what to eat, you can make a big difference in their symptoms. For colonic inertia specifically, or slow transit constipation, fiber or bulking agents may help. And importantly, for pelvic floor dysfunction, biofeedback is key. This could really help patients with pelvic floor dysfunction, is really one of the first things you're going to do for those patients. The next steps if fiber and water don't work would be various medications. So you could give pegylated based medications, which are osmotic laxatives, lubiprostone and linaclotide, which stimulate intestinal fluid secretion. For Hirschsprung's disease specifically, that's going to be a surgical intervention. And then opioid-induced constipation is a really big topic now, and there are a variety of medications available for this, including mu-opioid antagonists, such as methylnaltrexone and a variety of others. And then there are the stimulant laxatives, such as Senna. These cause colonic muscles to contract, and they're really indicated more for short-term use, and they could really be associated sometimes with pretty bad abdominal complaints or spasms and discomfort. So I do want to say a little bit about fecal incontinence. So incontinence is a major problem, particularly for elderly patients, especially women after vaginal delivery. The workup may include anal rectal manometry, colonoscopy, defecography. The colonoscopy would really to make sure that there's no colon cancer or inflammation. The goal for fecal incontinence is to increase stool bulk and improve anal tone. So one of the ways to improve anal tone in fecal incontinence is actually biofeedback. So you could kind of train patients to contract their sphincter muscles in response to what they think is an impending incontinent episode, and that could be very beneficial. In some cases, you could even use sacral nerve stimulation. It should be noted that incontinence can occur with impaction. So you could have a large mass of stool, particularly in elderly patients, maybe if they're on narcotics, and you could kind of get seepage around this large area of stool, and that could lead to incontinence. So you definitely want to do a rectal exam and make sure there's nothing like that present, and then you would disimpact them if that is the case. So constipation pearls, medications, especially opioids, are very common causes. Always review the med list. Think defecatory disorders such as pelvic floor dysfunction early on in the differential. That's kind of what we're moving to now. And for pelvic floor dysfunction, the main way to diagnose this is with anal rectal manometry, and biofeedback would be the main treatment for pelvic floor dysfunction. So irritable bowel syndrome, exceedingly common in primary care practices. At least 15% of the population is suffering from this at any given time. Generally, you're going to have abdominal pain and discomfort associated with disturbed bowel movements. Symptoms can worsen with emotional stimuli. There may be a history of PTSD or childhood trauma. Psychological dysfunction is common as well. You definitely want to exclude diseases that could overlap with IBS. So celiac disease would be a classic example, or lactose intolerance, or even bacterial overgrowth. So here are the Rome 4 criteria for IBS. I'm sure you've seen this before. It basically states that someone has recurrent pain/discomfort on average at least 1 day per week in the last 3 months, and it has to be associated with 2 or more of the following. So it needs to be related to defecation, associated with change in frequency, or associated with change in form. There are 2 main types. There's IBS diarrhea and IBS constipation. Sometimes there are mixed, these symptoms can be mixed, or there could be overlap. You definitely want to assure that there are no concerning symptoms like rectal bleeding, weight loss, etc., family history of colon cancer, because in these cases, you probably are going to want to do endoscopic evaluations and other tests. So treatment, this is not to be underestimated. One of the best things to do is to have a close relationship with your patient and reassure them. This could be followed by a low FODMAP diet. So FODMAPs are these fermentable sugars that, for example, fructose, that could be associated with bloating and change in bowel habits. So if you cut these out of the diet, this could have a substantial effect on your patient's quality of life. There are behavioral and cognitive therapies. You could use spasmodics, particularly if the patient is having a lot of abdominal discomfort. If the patient has IBS-D, tricyclic antidepressants can be useful because these TCAs tend to have antidiarrheal qualities to them. And you could try fiber and osmotic laxatives or PEG solutions particularly for IBS-C. Linaclotide, lubiprostone, these are used in IBS-C because they stimulate intestinal secretion. Antidiarrheals would be used for IBS-D. And then rifaximin is an interesting drug that could be helpful specifically for IBS-D if the patients have bloating. So really, IBS-D with bloating in combination, rifaximin is very useful. And then there's luxodolone, which is a new mu opioid receptor agonist and delta opioid antagonist that's used specifically in IBS-D. So again, there are a variety of these different medications and treatments, and you have to kind of tailor them to whether the patient has IBS-C or IBS-D. Question 15. A 68-year-old male presents with rectal bleeding, is found to have an ascending colon mass on colonoscopy with pathology showing adenocarcinoma. There's no family history of cancer. What do you recommend? Recommend first-degree relatives have starting at 40 and every 5 years afterwards. B, discuss with patient that this diagnosis won't affect lack of cancer family history. On colonoscopy biopsy specimen. E, recommend MSI testing on surgical resection specimens. Okay. This is kind of a tough one. Yeah, so it's kind of all, yeah. So I wrote this question a few months ago. So the answer is actually recommend MSI testing on colonoscopy biopsy specimens. So the reason that A is incorrect is because the guidelines, if somebody in your family is over 60 and they have colon cancer, the relative gets scoped at 40, but if their colonoscopy is normal, they get scoped every 10 years after that, not every 5. So it's a little tricky, but those are the US Multi-Society Task Force guidelines on colorectal cancer. The diagnosis can definitely affect the family members because even though the patient is older, there still could be a hereditary syndrome such as Lynch syndrome. And there's now a call for universal testing to screen for Lynch syndrome in all patients with colon cancer regardless of age. So you want to do MSI testing. And generally you want to do MSI testing on the colonoscopy biopsy specimen because the results could actually impact how much colon is resected when the patient goes to the OR. So it's a tough question. So colorectal cancer, there are a number of risk factors. We don't have to go through IBD, as we've mentioned, other risk factors, smoking. The diagnostic red flags for colorectal cancer would include anorexia, abdominal discomfort, particularly rectal bleeding. That is obviously a major concern for colon cancer, weight loss, change in bowel habits. The lifetime risk for anyone in the United States is about 6%. So it's actually pretty high. About 1 in 20 people will develop colon cancer by the time they're 70. And key point, there are rising incidence rates. I'm sure you've seen this all over the media, rising incidence rates in people under 50, actually under 54. And so you can't just assume that rectal bleeding in a younger patient is from hemorrhoids. You need to send those patients for colonoscopy. Other associations with colon cancer, this is like classically on tests, endocarditis due to various strep or Clostridium species would be a concern for colorectal cancer. And then there's something called advanced adenomas, which you need to know about. These are more likely to develop into colorectal cancer, and this would include a polyp with high-grade dysplasia, polyps with villus histology, or large polyps over 1 centimeter in size. Hopefully this question is a little easier. A 65-year-old male had a screening colonoscopy last month. He had no prior complaints or change in his bowel habits. On exam, he had 2 small adenomatous polyps, 48 millimeters, that were removed. What is the appropriate interval for follow-up? A, no follow-up. B, 1 year. C, 3 years. D, 5 years. All right, good. Most people got that. So it's just a straight up guideline. If you have 2 small adenomatous polyps, it's 5 years. So here are the guidelines. So these are the AGA guidelines from 2012. 1 to 2 small tubular adenomas, meaning less than 1 centimeter in size, 5 years. If you have 3 or more adenomas or 1 adenoma or sessile adenoma that's greater than 1 centimeters, or there's villus features, or there's high-grade dysplasia, it's 3 years. If you have greater than 10 adenomas on a single exam, that you're starting to be worried that the patient may have a polyposis syndrome, so you're probably going to scope that patient earlier than 3 years. If a polyp is taken out piecemeal, meaning in chunks, it has a high risk of regrowth, so you're going to want to scope that patient again in 2 to 6 months. If you have a sessile serrated polyp less than 1 centimeter with no dysplasia, it's 5 years. And if you have a sessile serrated polyp greater than 1 centimeter or a sessile serrated polyp with dysplasia or something called a traditional serrated adenoma, it's 3 years. It's just straight up memorization, these guidelines. I would say that these are the most common things that you would counter on a test. These are pretty basic, these first 2 points here. There is something called serrated or hyperplastic polyposis syndrome, which I think people should be aware of because there's a high risk of colon cancer in these patients. So these are the criteria. You could read about them. I'm not going to go through it just due to time constraints, but just keep in mind that there is a high risk of colon cancer associated with that syndrome. So question 17. You have a 40-year-old patient with familial adenomatous polyposis. He had a colectomy at age 20 and has done well with no complaints. You now recommend A, CT brain, B, upper endoscopy, C, upper GI series with small bowel follow-through, or D, an MRI of the abdomen. Good, most people got that right. So in FAP, patients have a high risk of developing duodenal polyps, duodenal adenomas, and ampullary lesions. So that would be the test that you'd want to do at that time, particularly in a patient who's already 40 with FAP. Okay, so now we're going to switch gears to these, well, we're going to continue to talk about these inherited colorectal cancer syndromes. So they could either be polyposis or non-polyposis. So the polyposis syndromes include mainly these 4 syndromes. And generally, if a patient has had 10 or more lifetime adenomas, not just on one colonoscopy, but cumulatively over their entire life, you want to consider genetic testing for these syndromes. So there's familial adenomatous polyposis, which is autosomal dominant on the APC gene. And you've seen this before. People present in teenagers, 20s, with hundreds, thousands of polyps. And as we mentioned, they could get duodenal adenomas, ampullary carcinoma. There's something called attenuated FAP, which is actually on the same gene, but just in a different location. And it's associated with fewer polyps, but still there's a high risk of colorectal cancer. In FAP, the lifetime risk of colon cancer approaches 100%. So those patients are going to get a colectomy. It's a question of when, not if. There's something called MUTYH polyposis, which is autosomal recessive in contrast to autosomal dominant in these 2. And it kind of looks like attenuated FAP. So there's like fewer polyps than traditional FAP, maybe 10, 20, 30, 50, 100, something like that, but not thousands. And then there's Gardner syndrome, which is a variant of FAP with tumors outside of the colon. This can include osteomas, thyroid cancer, and desmoids. Other polyposis include Peutz-Jeghers syndrome. So this, I mentioned in the GI bleeding section, you could get multiple hematomatous polyps in the small bowel. that can bleed. They could also be seen in the stomach and the colon. It's associated with freckles on the lips and the buccal mucosa. The polyps, particularly in the small bowel, could lead to intussusception, and there is an increased risk of a variety of cancers. So colon cancer, 39%. Importantly, breast cancer is up to 50% lifetime risk, and pancreatic cancer, this is one of the highest risk factors for pancreatic cancer at 11 to 36% lifetime risk. Then there's juvenile polyposis, which you need to consider if you see 3 to 5 juvenile polyps of the colon or multiple juvenile polyps throughout the juvenile polyposis syndrome. The lifetime colon cancer risk is about 40 to 50% in these patients. So now we're going to talk. So the most common here is Lynch syndrome. This used to be referred to HNPCC, but it's no longer referred to as HNPCC in the literature. It's associated with 4 different mutations: MLH1, MSH2, MSH6, and PMS2. And you may remember the Amsterdam criteria, the 3-2-1 rule. 3 relatives over at least 2 generations with 1 person diagnosed less than 50. Unfortunately, these criteria are so stringent that they miss a lot of people with Lynch syndrome, which is why it's now recommended that if someone has colon cancer, you do MSI testing on regardless of their age, because you want to catch everybody with the syndrome. So again, here's the universal testing guideline. MSI testing, ideally on the colonoscopy biopsy specimen, so that we have the information before the patient goes to the OR. And the other thing is that you may be seeing patients in your clinic that don't have cancer themselves, but have a strong family history of cancer. So those patients may be eligible for genetic testing, and there's something called the PREM model, or the prediction model for gene mutations. You could actually just Google this in your clinic, and it's a little calculator, and you just kind of put in the family history, and it'll tell you whether the person needs genetic testing based on their family history. So Lynch syndrome, the risk of colon cancer, lifetime risk is very high. It's up to about 80%. And Lynch syndrome and a number of others. So in females, a lot of times the patient's going to need a THBSO has been reached. So just talking about colorectal cancer screening for kind of average risk people. So there are a number of different guidelines. So the U.S. Multi-Society Task Force on Colorectal Cancer recommends as first-tier tests colonoscopy every 10 years or yearly FIT testing. So in the guidelines, they say specifically that you offer a colonoscopy first because of the higher sensitivity for polyps and cancer compared to FIT testing. And then you could offer a FIT testing afterwards. There are other guidelines that differ from these, but these are the Multi-Society Task Force guidelines. They talk about some second-tier tests like CT, FIT fecal DNA, and even third-tier tests like something called a capsule colonoscopy. There are other guidelines, including the U.S. Preventative Services Task Force, the American Cancer Society, that may differ somewhat from these guidelines, but overall they're fairly similar. So generally, if someone is average risk, meaning they have no symptoms and no family history, you're going to want to start screening them at age 50. However, I'm sure you've all seen this. In 2018, the American Cancer Society came out and said that every single patient that's average risk should start screening at age 45 instead of 50. All right. In African Americans, most of the guidelines agree, however, that you should start at age 45, not 50, because of higher incidence, mortality, and early onset disease. And again, the rates are rising in people under 50, so you have to take symptoms very seriously. Rectal bleeding is not necessarily from hemorrhoids. You need to make sure that person gets a colonoscopy. And here you could see the guidelines on family history. This was in the question that I asked. So if you have a family history of colorectal cancer or adenoma in a first-degree relative under 60, you will start doing a colonoscopy every the earliest diagnosis in the family. If you have a first-degree relative diagnosed over age 50 with colorectal cancer or an advanced adenoma, you start screening at age 40, average risk. So if the colonoscopy was normal, you would probably repeat it in about 10 years. And please be aware that in here you see that it's not just a family history of colon cancer, it's a family history of an advanced adenoma. So if someone has a polyp with high-grade dysplasia, a polyp over a centimeter, or villus histology, that's going to trigger an earlier colonoscopy in the relative. So if you're higher risk, and for example, if you have a strong family history or you have a history of polyps or cancer, you're not going to want to do stool-based tests. You're going to want to do a colonoscopy because that's the highest sensitivity exam. I would urge everyone to read the colonoscopy reports in their clinic, or if this shows up on a test. You need to look at the quality indicators for colonoscopy because not everyone is doing colonoscopy in the same way. You want to make sure the cecum is reached at least 95% of the time. You want to make sure that the person doing the colonoscopy is detecting adenomas at an adequate rate. That's called the adenoma detection rate. You want to make sure that they're not pulling the colonoscope out really quickly. They need to be taking at least 6 minutes to look around because that will increase your adenoma detection rate. In terms of, staging for colon cancer, there are really two ways to stage. There's the Dukes and the TNM. Most people use the TNM. So you could have carcinoma in situ, the basement area, which was intramucosal. As you start increasing, really not as remove T1 lesions, which are in the submucosa, depending on how deep it is and how close and how different stages, then you're talking about surgery and chemotherapy. At TNM stage 3, that's when you have nodal involvement. And obviously at TNM stage 4, that's when you have distant mets. This is just a cartoon showing the stages. You could see here, this would be like a carcinoma in situ. This is a polyp that we could probably just take out with a snare during colonoscopy. But the larger these get, you're going to need surgery. So colorectal cancer pearls, increasing rates of colorectal cancer in young patients. Take all symptoms very seriously. Don't assume bleeding is from hemorrhoids. Advanced adenomas, if you have an advanced adenoma, in 2014, you're going to get a colonoscopy in 2017, 3 years later, not 5 years. Lynch syndrome is a common hereditary syndrome. Again, universal MSI testing on all colorectal cancer patients now. And if you have greater than 10 lifetime adenomas, you want to think that a polyposis syndrome, such as FAP, could be present. So we'll switch gears and talk about some other intestinal diseases. So diverticular disease. This is very common. Most people with diverticular disease are asymptomatic. Sometimes you could get painful diverticulosis, diverticular bleeding, and diverticulitis. Diverticular bleeding is actually the most common cause of GI bleeding in the elderly, and it typically stops spontaneously. And the classic presentation is painless maroon stool. Please note, though, that sometimes this could be confused with an upper GI bleed. So if the patient's unstable or the BUN creatinine ratio is greater than 30:1, if you see this on a test, you would want to make sure that there's not an upper GI bleed present. Diverticulosis is caused by inflamed diverticula due to microperforations. Fortunately, it occurs in less than 5% of patients with diverticulosis. You could have a variety of symptoms and signs, including left lower quadrant pain, fever, high white count, etc. Really, these patients are diagnosed by CT scan. And a key point, you do not want to do a colonoscopy in these patients, right? Because you could perforate them. So generally, you want to wait about 4 to 8 weeks before you set the patient up for a colonoscopy. So diverticulitis, the presentation really depends on two factors. You want to keep these divisions in mind. There's the severity, and then there's the presence of complications. So uncomplicated diverticulitis just means it's localized. Complicated diverticulitis means that there may be an abscess, a phlegmon, or a fistula. And a lot of these may require specific treatments like drainage or surgery. Keep in mind also that people with uncomplicated disease could actually be very sick and have severe disease. They could be septic, even though they don't have a discrete localized complication. And the AGA suggests colonoscopy after resolution to make sure there's not an underlying cancer. Again, you want to wait about 6 to 8 weeks because of the risk of perforation if you do a colonoscopy in the setting of active diverticulitis. In terms of treatment, the general categories would be mild diverticulitis. Most of these are going to be uncomplicated cases. I'm not going to really go into details of all these antibiotics, but the bottom line is if it's mild, you could generally get away with outpatient PO treatment. If it's moderate to severe, you're going to really need to have broad spectrum IV antibiotics. And if there's a specific complication present, like a phlegmon, it may need to be drained. Some other intestinal diseases include angiodysplasias or AVMs. This is the second most common cause of bleeding in the elderly. The number one cause is diverticulosis. Most of the time it bleeds from the right colon or the cecum, but a lot of times we'll see these AVMs in the small bowel as well. Angiography could be helpful to localize the AVMs, but now that we have capsule endoscopy, we could frequently see them that way as well. Keep in mind that angiography could also be used for treatment of mesenteric ischemia and could be used for treatment of upper and lower GI bleeds by embolizing vessels. AVMs could frequently be controlled by endoscopic therapies, generally coagulation or something called argon plasma coagulation, which is beyond the scope of your test. In terms of intestinal ischemia, these are important entities to know about. There are four main types. The first is acute mesenteric ischemia. That's the most dramatic one, where the patient comes in with severe abdominal pain out of proportion to exam. There may be lactic acidosis, particularly if it's been going on for a while. Generally, there's going to be a clot in the SMA that's going to cause low blood flow distally. These patients are very sick. They often have associated cardiac comorbidities like AFib. There are a variety of ways to diagnose it, but if the patient is exceedingly sick, they're going to go directly to the OR. Sometimes if they're not as sick, you may get a CT angio or even send them to IR. IR is good because you can not only diagnose it, but it could be therapeutic by thrombolizing the clot. There is ischemic colitis, which is another subtype of intestinal ischemia. So in this case, the ischemia specifically involves the colon, and it's really non-occlusive. So it's not like you have a clot in the SMA like in mesenteric ischemia. It may just be from watershed areas, like if the patient's globally hypotensive, then there may be a watershed area in the colon that could develop an area of ischemic colitis. Most cases resolve quickly without intervention, but if there are if there's moderate or severe disease, if there's abdominal peritoneal signs or fever, that kind of a thing, then you're going to want to start the patient on antibiotics. I should note that if you see isolated right-sided ischemic colitis, studies have shown that has a higher mortality than other areas of ischemic colitis. And the reason for that is there actually may be distal SMA disease. So it's almost like an offshoot of mesenteric ischemia involving the distal SMA branches. So the mortality for that is higher. This is an X-ray showing thumbprinting of the transverse colon. You can see these indentations here. This just implies that there's edema in the colonic wall. So it's not necessarily specific for ischemic colitis, but it would be consistent with ischemic colitis if you saw this on a test question. The third type of intestinal ischemia is chronic mesenteric ischemia. So this is the intestinal angina. So it's really synonymous with cardiac angina. So it's a supply-demand issue. So if you have narrowed mesenteric arteries and you're eating food, then you need to increase blood flow to your gut. But because there are fixed areas of stenosis, you can't get the blood supply up in your gut, and you're going to get abdominal pain. And generally, you're going to get pain about 1 to 3 hours after eating a meal. It's often dull and gnawing. These people often have risk factors for cardiac disease, their vasculopath, smoking history. And generally, you're going to diagnose with an MRI or a CT angiogram. You have time in this case because it's not an acute mesenteric ischemia, right? The symptoms have gone on for months to years. So you can usually do MRA, CT angiogram, or you may need a surgical bypass. The fourth type of intestinal ischemia is mesenteric venous thrombosis. So this is associated with hypercoagulable states. So for example, pancreatitis, which could lead to splenic vein thrombosis, cirrhosis, which could lead to portal vein thrombosis, and a variety of other conditions associated with thrombotic conditions. If you get splenic or portal vein thrombosis, that could lead to variceal bleeding. Generally, you're going to diagnose this with a CT scan with contrast, and you'll be able to see clots in the mesenteric veins. And sometimes you could treat in the acute setting with thrombolytics, but generally long-term anticoagulation is you'll need to have those patients on long-term anticoagulation. So some surgical issues in luminal bowel disease, acute appendicitis. This usually, it shouldn't say diagnosed clinically, it should usually be suspected clinically, right? One of the classic presentations is periumbilical pain that starts in that area and then it kind of migrates to the right lower quadrant. The patients may have anorexia, mild leukocytosis. On labs, it's kind of the classic presentation. The way to diagnosis is really CT scan or sonogram. In some scenarios, you won't actually use a CT scan. So for example, if you have a pregnant woman that you don't want to expose to radiation, you could use a sonogram, or if you have a child that you don't want to expose to the radiation of a CT scan, you could use a sonogram for diagnosis. Other surgical issues would include bowel obstruction. So this, we commonly are consulted on this in the hospital. There are a variety of causes. Post-op adhesions would be one of the most common. You could have tumors either in the small bowel or the colon. Diverticulitis could actually sometimes cause an obstruction, a colonic obstruction, and then there's a sigmoid volvulus, which could cause an obstruction. Generally, the first step is to get an abdominal X-ray, and tip for a test, if you see air fluid levels at different heights, that suggests an obstruction as opposed to an ileus. In ileus, you're more likely to see the levels at the same height. So treatment would be IV fluids, NG suction, call surgery, correct electrolytes, minimize narcotics, pretty intuitive. If you have a sigmoid volvulus specifically, generally you're going to call GI, because we could actually get a scope in there and kind of tether it through the area that's twisted and kind of untether it. But usually those patients are at risk for reforming the sigmoid volvulus, so they're ultimately going to need surgery afterwards. And if you see this on a test, this coffee bean, so I put a picture of a coffee, it does really look like a coffee bean, right? It's like that. So that is classic sigmoid volvulus on an X-ray. So that would be a good thing for you to know. Question 18, a 35-year-old female presents to the ED with severe epigastric pain for 12 hours. It radiates to the back. So this is not dyspepsia, right? Like we were talking about before. It's associated with vomiting. It's constant. She's never had it in the past. She admits to quote unquote social drinking. She doesn't smoke. Moderate to severe pain on exam. Billy is a little elevated. Liver test a little bit elevated. Amylase is elevated. Of these listed options, what should be ordered next? Great, most people got this. So, the concern is for pancreatitis, obviously, right? It doesn't look like the patient has cholangitis, so you're really not going to jump to an ERCP. You're not definitive on what the person has, so you're not going to just go tell the surgeon to take their gallbladder out, right? And then an EGD is really not going to be that helpful. So the MRCP would really be the best option. A sonogram, if that were listed, would also be a good option to look for gallstones or a dilated duct, common bile duct, which could be associated with gallstone pancreatitis. So acute pancreatitis, etiology, the two main ones that everyone needs to know are alcohol and gallstones. There's also post-ERC pancreatitis, which occurs in up to 5% of patients undergoing an ERCP, which is why we don't do ERCPs as frequently now. So now we have endoscopic ultrasound and MRCP, which we could see the anatomy really well, so we don't really need to do ERCP for diagnostic purposes. We really just do it for therapeutic purposes now. There are drug-induced causes of acute pancreatitis. Classic would be like azathioprine, diuretics like furosemide. Those would be classics on a test. Other etiologies, again, classic things that might show up on a test: hypertriglyceridemia, generally greater than 1,000, hypercalcemia. Sometimes people are labeled as having, quote unquote, idiopathic acute pancreatitis, but really what's going on is they may have little biliary crystals that are forming and kind of clogging the pancreas that may not show up on a sonogram. Patients could have an undiagnosed case of cystic fibrosis, which could lead to acute bouts of pancreatitis. And importantly, key, occult malignancy, right? You always want to rule that out. You always want to make sure the patient does not have pancreatic cancer. So the ACG guidelines say always consider pancreatic tumor in patients greater than 40 with acute pancreatitis. In terms of diagnosis, according to the ACG, you really need 2 out of the following 3 criteria. So you need upper abdominal pain radiating to the back. You need an amylase or lipase 3 times the upper limit of normal. And you need a CT or MRI consistent with acute pancreatitis. So you need 2 of those 3 things. The lipase is generally a better test than amylase because it's more specific and it often stays elevated beyond day 7. As you can see here, there are a number of causes of high amylase. So there's salivary amylase. Amylase can even come from the gallbladder or perforated ulcer. So really, the lipase is a better test. You could also have macroamylasemia, which are benign macromolecules with low urinary excretion, and that could lead to a persistently high amylase in a patient without even having ever had pancreatitis. When we're talking about the severity of pancreatitis, there's something called the Atlanta classification. So it's divided into mild, moderate, and severe. Mild is no organ failure and no local or systemic complications. Moderate means that there's transient organ failure that resolves within 48 hours and or local or systemic complications, for example, cardiac or respiratory complications, but no persistent organ failure. Okay, that's the key. If it's severe, if there's persistent organ failure, okay, that's the key for more than 48 hours. And again, in another classification, there are two main types of acute pancreatitis. There's interstitial and necrotizing, all right? According to the AGA, necrotizing pancreatitis is characterized by pancreatic or peripancreatic necrosis and is typically seen in patients with moderately severe or severe acute pancreatitis. And keep in mind that necrosis does not necessarily mean infected necrosis. You could have necrosis with no infection. So some characteristics associated with a severe course of pancreatitis would be older age, elevated BMI, comorbid diseases, evidence of systemic inflammatory response, which I outlined here if you need to see that. BUN greater than 20 or a rising BUN, which would imply that you're kind of hemoconcentrated, as would a high hematocrit. Radiology findings showing disease outside the pancreas, so pleural effusions, pulmonary infiltrates, extrapancreatic collections, those are all bad signs. Clinical signs would include the Cullen sign and the Gray-Turner sign. So the Cullen sign is the discoloration around the umbilicus, and the Turner-Gray sign is discoloration in the flanks. So here you could see, this would be the Cullen sign. So you could have, you see some hemorrhage here around the periumbilical area. So if you see that on a test, that would be very indicative of acute pancreatitis. There are a number of scoring systems that you may see out there: Ranson, Glasgow, Apache. I'd say the Ranson is what they really like to hone in on. That's probably the most tested. So I'm sure you've seen this before. There are 5 criteria admission, and then 6 criteria during the next 48 hours. And you plug these variables into the Ranson calculator, and the higher the points, the higher the mortality. Key points about this are that if the BUN is high or the hematocrit falls, both of these things imply that you're not keeping up with IV hydration or IV fluids, which is bad for, you really want to keep up with IV fluids for acute pancreatitis. Assessment and management, you want to assess for fluid loss, assess for cardiopulmonary involvement. The labs we already discussed, you definitely want to check a triglyceride level and calcium levels, because this can clue you into the etiology. You want to do a sonogram to rule out gallstones. And this is a really key point. They do this all the time in the ER. Everyone just gets a CT scan, right? You don't have to do a CT scan in acute pancreatitis. It's not always recommended at initial presentation, really, unless there's diagnostic uncertainty. And the other thing is necrosis may not fully manifest until several days after admission. So a lot of times when these people are getting the CT scan in the ER, it's really pointless. It's probably better to do it a little bit later. And as I just stated, CT may be required later in admission in moderate to severe cases, and particularly if the patient's not doing well with your therapy, right? Because you want to make sure that there's no complication from the pancreatitis. Early aggressive IV fluid replacement is critical. According to the AGA, there's really no distinction yet between whether you should give NS or Ringer's lactate. Although IV hydration is really important, you definitely have to be aware that you can't overly aggressively hydrate patients either, because that could lead to cardiopulmonary issues. And you really need to monitor the patient closely. That's why these patients need to be in the ICU. You don't want them just on the floor, like getting a slow drip or getting too much without people monitoring them. You want to monitor the BUN with IV fluids. The change in BUN can predict mortality, actually. So you really want the BUN to come down, which implies that you're adequately hydrating the patient. And early adequate fluid replacement may be associated with decreased morbidity and decreased mortality. Persistent hemoconcentration can be associated with necrotizing pancreatitis. Again, all pushing for adequate IV fluid hydration. Other key points about acute pancreatitis is there's always been this concern like, oh, if I feed the person orally, I'm going to stimulate their pancreas and it's going to make the pancreatitis worse, right? We've all heard that. That's not really what's going on nowadays in the literature. You want to try for oral refeeding, particularly if there's no nausea, vomiting, or evidence for ileus. And if the patient can't tolerate oral feeds, generally you want to give enteral feeds before you give them TPN. Enteral feeding is better than TPN because it maintains the intestinal barrier and it prevents gut bacterial translocation. So that's really a key point. There are lots of key points in acute pancreatitis, lots of testable things. So prophylactic antibiotics are not recommended regardless of the severity or type of pancreatitis, even if it's necrotizing, right? You don't want to just throw antibiotics at people. You want to use it on demand if you're concerned, if the patient is deteriorating. And according to the AGA, if there's gallstone-related pancreatitis, you want to consider a cholecystectomy during the same admission due to better clinical outcomes, because sometimes you could send a patient home without a cholecystectomy and they could come back with the same thing. Some complications you have to be aware of in acute pancreatitis. You could see acute fluid collections, generally 1 month or earlier. You could get acute necrotic tissue collections 1 month or earlier. Pseudocysts generally take a while to really encapsulate and form, so you're going to see them after about 1 month. And then you could see walled-off necrosis after about a month as well. Acute necrotic tissue collections and walled-off necrosis can become infected, but they don't always become infected, which is why you don't always throw antibiotics at these patients. You need to consider infection, however, if the patient fails to improve, gets worse, or develops signs of sepsis. If this is the case, you're going to want to start the patient on antibiotics, and you may want to consider getting a CT with an FNA and a gram stain and culture to confirm the infection, and these patients may require debridement. One key point is that if they require debridement, a lot of times you want to wait generally till after 4 weeks if you can, because you want these collections to become more walled off and discrete because it's easier for the surgeon to deal with. Now switching gears to chronic pancreatitis. This is commonly a result of alcohol ingestion usually for more than 10 years, although there are exceptions to this. Usually there's an asymptomatic phase followed by recurrent bouts of pain. Steatorrhea and diabetes may develop late in the disease once 80 to 90% of endocrine and exocrine function is lost. And not only can chronic pancreatitis be confused with pancreatic cancer, but chronic inflammation in the pancreas is actually a risk factor for the development of pancreatic cancer. So any patient with chronic pancreatitis, you have to be on the lookout for pancreatic cancer. Risk factors for chronic pancreatitis, probably the most important would be alcohol. Smoking is also important. Genetics, so cystic fibrosis. Patients may have kind of like a low-grade cystic fibrosis mutation that may actually be leading to recurrent bouts of pancreatitis and ultimately chronic pancreatitis. There's some other genes that are associated with hereditary pancreatitis, including PRSS1 and SPINK1. What you need to know about these is that these mutations are associated with poor control of trypsin activity, which could lead to enzyme activation and pancreatic damage. There's also an entity called autoimmune pancreatitis, which I'll get to in a second, and systemic diseases like lupus that could cause chronic pancreatitis as well. So the diagnosis of chronic pancreatitis, the classic triad is really unusual to see, unfortunately. The triad would include pancreatic calcifications, for example, on an X-ray, diabetes, and steatorrhea. The abdominal X-ray is only 30% sensitive, but it is very specific. If you see a bunch of calcifications in the central area on an X-ray, it strongly suggestive of chronic pancreatitis due to calcifications in the pancreas. CT abdomen is more sensitive, and it could show other things like a dilated pancreatic duct or pancreatic atrophy. MRI is often used instead of CT scan because it could get a better look at the pancreatic duct. And as I mentioned before, ERCP is almost never used to diagnose chronic pancreatitis. So if it's chronic pancreatitis on a test question and ERCP is in there, it's probably not the answer, right? Because the risk of, you could cause acute pancreatitis by doing the ERCP, and the MRCP can really help you see the anatomy. There's something called a double duct sign, which means that the biliary tree and the pancreatic duct are dilated at the same time. If you see this, you want to rule out a pancreatic head mass, okay? And the other cause for this would be chronic pancreatitis. So pancreatic head mass is going to compress distally, and it's going to cause the PD to dilate and the CBD to dilate at the same time. And chronic pancreatitis can do the same thing. EUS is sometimes used in specialized centers. I think it's probably beyond the scope of this course, but there are certain EUS features listed there that would help make the diagnosis of chronic pancreatitis. Amylase and lipase are really not useful for chronic pancreatitis because there's not necessarily any acute inflammation going on, right? It's more scarring. So these are probably not going to be elevated. Fecal elastase, on the other hand, is very useful to diagnose chronic pancreatitis. So fecal elastase is a pancreatic protease that's seen, and you see very low values in chronic pancreatitis. And then there's something called the secretin stimulation test, where you collect duodenal fluid after secretin stimulation and you assess for bicarb. And if the bicarb is low, it's consistent with chronic pancreatitis. But I'd say like the fecal elastase is a really good test, so we're not really doing secretin stimulation tests as frequently. Complications of chronic pancreatitis. Pseudocysts could form if you're having acute on chronic bouts of pancreatitis. Cancer, as I mentioned, chronic inflammation is a risk factor for pancreatic cancer, and it could develop 4% after about 20 years. You could get splenic vein thrombosis in the setting of actually acute or chronic pancreatitis, and that could lead to gastric varices, which are right here in the fundus. So again, this is the scope in the stomach, and it's kind of looking back at itself. This is a big gastric varix. You could get endocrine insufficiency, and patients could present with diabetes. And the pancreas could also produce less glucagon, so the patients could actually develop hypoglycemia because there's no glucagon to increase glucose. So that's another hormonal downstream effect of chronic pancreatitis. Treatment, the main thing to do really, you really want to take away the inciting factors. So tell the patient to stop drinking. Smoking is terrible for chronic pancreatitis. You want to eat small meals that are low in fat. You want to assure adequate fat-soluble vitamin levels are present. And then really key is you want adequate pancreatic enzyme supplementation for the steatorrhea. So the key number here is 30,000 international units of pancreatic lipase per meal. So make sure you know that. Not only can the enzyme supplementation help with steatorrhea, it could actually decrease pain in chronic pancreatitis due to a feedback mechanism. Sometimes we could do endoscopic therapy. For example, if there's like a stone in the pancreatic duct, we may be able to remove that stone. And then there's surgery. So in chronic pancreatitis, particularly if someone has a dilated pancreatic duct, the surgeon could kind of fillet open the pancreatic duct and attach it to the jejunum and decompress the whole system, and that's called a Pusteau procedure. Autoimmune pancreatitis, this is being more commonly recognized as an entity. It could lead to acute pancreatitis or chronic pancreatitis. It really occurs in a minority of chronic pancreatitis cases, though. Generally, CT will show a head mass lesion or diffuse enlargement, and it could really look like cancer. So you really have to be on the lookout and try and make the distinction between the two. There are two types of autoimmune pancreatitis. There's type 1, which has an elevated IgG4, and it's associated with systemic disease, including salivary disease and even bile duct disease or IgG4-associated cholangitis. And then there's type 2, where the IgG4 is normal and there's no systemic disease. So these are the two main types. If you were to biopsy the pancreas, you would see a lymphoplasmacytic infiltrate, and the treatment would be prednisone. And here is a picture of a sausage-shaped pancreas. That would be typical of autoimmune pancreatitis, but could be confused with cancer. Pancreatic cancer, 80% present with advanced disease, so only 15 to 20% are eligible for a Whipple procedure, unfortunately. The risk factors include smoking, probably heavy alcohol. This is often a confounder in studies with smoking. Other risk factors, male obesity, Peutz-Jeghers syndrome, I already mentioned this, has a very high risk of pancreatic cancer. Lynch syndrome, even BRCA is associated with a risk of pancreatic cancer. And then there's something called familial pancreatic cancer, where there's a clustering of pancreatic cancer in families, but no specific mutation is identified. And the tumor location really helps determine how the patient is going to present. If it's in the head of the pancreas, patients will usually present with painless jaundice. If it's in the body and tail, it may present much later because there's no compression of the common bile duct in many cases. I do want to talk a little bit about pancreatic cystic neoplasms because we see this all the time. You'll order a CT scan and you'll get like these incidentalomas, right? So you need to be familiar with these. There's something called an IPMN, intraductal papillary mucinous neoplasm. These connect with the PD. They can have a malignancy risk, particularly if they involve the main pancreatic duct. There is something called a mucinous cystic neoplasm, which has large macrocystic spaces. And this also has a significant malignancy risk. And then there's something called a serous cystic tumor, which has microcystic spaces, in contrast to macrocystic here, a central scar, and a low risk for malignancy. And here's a picture of a central scar in a serous cystic neoplasm. Again, very low malignancy risk in this. And pancreatic neuroendocrine tumors, I think these were probably covered to some degree in your endocrine section. So you could get a number of tumors secreting various hormones. So you could get a glucagonoma. The key thing with this is that it's associated with a rash called necrolytic migratory erythema. So if you see that on a test, that is synonymous with glucagonoma. You could get an insulinoma, where you could get bouts of hypoglycemia. Gastronoma, we've already discussed. VIPomas secrete VIP, which leads to intestinal fluid and electrolyte secretion. So you get profuse watery diarrhea and low potassium. And then there's actually a serum test for VIP that you could check in your clinic. So pancreatic disease pearls, alcohol and gallstones are main risk factors for acute pancreatitis. Routine CT not always recommended at initial presentation unless diagnostic uncertainty. Early adequate fluid, key, right? That will decrease morbidity and mortality. In acute pancreatitis, routine prophylactic antibiotics are not recommended. You do it on demand if you're worried about the patient. If there's a double duck sign, remember dilated CBD and dilated PD, rule out pancreatic cancer. The other cause for that is chronic pancreatitis. And autoimmune pancreatitis is treated with steroids. So now we're going to shift gears a little bit, start going into the liver. 49-year-old male with longstanding UC developed mild right upper quadrant discomfort several weeks ago. He denies diarrhea and has not seen any blood in his stool. He went to a local urgent care because his wife said he looked yellow. Labs were drawn, and he's here today to review it with you. And you can see here that his bilirubin is elevated, as is his alkaline phosphatase. You are most concerned about gallstones, so you order a sono. PUD, so you set up an EGD. Colon cancer, so you refer to GI for a colonoscopy. PSC, so you order an MRCP. All right, good. Most people got this. So, you know, it's classic IBD-associated elevated alkaline phosphatase, so you want to get a good look at the bile ducts. I will say, though, that it wouldn't be unreasonable to get a sonogram as well. That's not the best answer to the question, but a sonogram, common things being common, people could have gallstones, stones in the common bile duct, but because this patient has UC, you want to make sure the patient doesn't have PSC, and the best test is an MRCP. So the biliary system, gallbladder stones, cholelithiasis, very, very common, often asymptomatic, more common in women. Most are cholesterol stones. The rest are pigmented stones because they contain bilirubin. Typical profile for cholesterol stones would be an elevated BMI, rapid weight loss, female pregnancy. Profile for pigment stones would be old age, sickle cell disease, or other causes of hemolysis because of the increased unconjugated bilirubin. Sonogram is really the best test. It's the most sensitive test to look for gallstones. They could be missed on CAT scan. A HIDA scan is really done if you want to look for cystic duct obstruction, if you're concerned about acute cholecystitis. In a symptomatic patient, you definitely want to send those patients for cholecystectomy because they have a 70% chance of recurrent symptoms if surgery is not done. If they're asymptomatic, only 20% will present with symptoms, so a lot of the times they could be monitored. But you may need to consider prophylactic cholecystectomy in certain populations. So if you see a porcelain gallbladder or large gallstones, those people have a high risk of having gallbladder cancer. So even if they don't have symptoms, you may want to send them for surgery. And then there's an entity called acalculous cholecystitis where there's no stones in the gallbladder, but there's a thickened wall, and it's often seen in the ICU patients. So these patients, it's often seen in patients in the ICU. So these patients will have a positive HIDA because the cystic duct really is obstructed from inflammation, but there's no stone. In terms of CBD stones, choledocholithiasis is frequently seen. It could even be seen after a patient has had a cholecystectomy. People could walk around for years with a stone in their common bile duct after they've had their gallbladder removed. There's something called Maritzi syndrome where you could get a stone in the cystic duct and it pushes on the biliary tree. So even though there's no stone in the biliary tree, you can actually get kind of a pseudo obstruction because of the stone in the cystic duct pushing externally. The CBD stones are removed by ERCP, so this is a fairly easy and straightforward test to do. Beware that CBD stones can cause cholangitis. Clinical predictors of CBD stones in patients would include, this is good for your clinical practice, would include a CBD stone on sono. Obviously, that's kind of a slam dunk. If the billy is greater than 4 or there's clinical ascending cholangitis, I mean, obviously pretty much slam dunks. But if you see a dilated CBD greater than 6 millimeters or kind of a moderately elevated billy, that could definitely indicate that there's a CBD stone present. So cholangitis, you've probably heard of this, the Charcot's triad. That's biliary, colic, fever, and jaundice. That indicates that cholangitis is present. There's the Reynolds pentad, which adds altered mental status and septic shock to the mix here. And you could see a stone in the bile duct and backup, probably with pus here causing cholangitis and some stones here in the gallbladder. The treatment is pretty simple. It's broad spectrum antibiotics and rapid urgent biliary drainage with ERCP. And here you can see this is the duodenum with the ampulla with pus coming out of it during an ERCP. So biliary system non-stone disease, so PBC, fairly common disorder. 95% are women, typically middle-aged. It's considered an autoimmune disease. But really what's going on here is you have toxic bile acids that accumulate in the liver and they damage the bile ducts, and this leads to chronic liver disease and eventually cirrhosis. So the common presentation would be fatigue and an elevated alk phos and pruritus. And key here is the AMA, the anti-mitochondrial antibody. 90% have this, but the degree of elevation does not. I repeat, does not correlate with severity of disease. Because bile is involved, you could see fat-soluble vitamin deficiencies, including A, D, E, and K. So it's important that you assess for decreased bone mineral density in patients with PBC. And you could also see very high cholesterol levels because of difficulty secreting cholesterol into the bile. So the diagnosis, liver biopsy is not always performed. It may be done if there's diagnostic uncertainty or if you need to figure out if there's cirrhosis. If you were to do a biopsy, and this could definitely show up on a test, you would see what's called a florid duct lesion, which is inflammation around the bile duct. So if you see a bile duct and a bunch of lymphocytes and neutrophils around it, that would be consistent with PBC. And you could also see granulomas. URSO is the treatment. It's a synthetic bile acid that reduces the toxicity of the bile salt pool. And not only does it slow progression of disease, but key point, it decreases mortality and it decreases the need for liver transplantation. PSC, we've already talked about this a few times, strongly associated with IBD, either UC or Crohn's, but more commonly associated with UC. The cause is unknown, but basically what's going on is you get inflammation and scarring of the biliary tree. In contrast to PBC, the AMA is negative, but you often have a positive P-ANCA. You should always think about this in IBD patients with persistent increase in alk phos, and they should be screened, ideally with an MRCP, not an ERCP. An ERCP is actually really dangerous in PSC because you can introduce bacteria into the biliary tree and cause cholangitis. Similar to PBC, you could see deficiencies in fat-soluble vitamins, and importantly, there's a high risk of developing cholangiocarcinoma. So this might show up as a dominant stricture on an MRCP or an ERCP if the ERCP was done. But sometimes this could be difficult to distinguish from a benign stricture. Sometimes you could do biliary brushings or biopsies. This can sometimes help establish this diagnosis, but not always. As we've mentioned, patients with UC and PSC are at increased risk of colorectal cancer compared to UC alone. And as soon as you make that PSC diagnosis, if the patient has UC, you start doing surveillance due to the risk of colon cancer associated with ulcerative colitis. There's also an increased risk of gallbladder cancer in patients with PSC. If you were to do a biopsy, which is almost never done, you would see onion skin fibrosis. So you could see these bands around the bile duct, and that's typical of PSC. And here again is that picture of the ERCP with the narrowing of the biliary tree with the beaded appearance. That's typical for PSC. Really, the only treatment for PSC is liver transplantation. Colectomy could certainly cure UC, but it will not affect the course of PSC, unfortunately. Remember, any patient with jaundice, elevated alk phos, history of IBD, rule out PSC in real life or on a test question. So biliary disease pearls, pigment gallstones are associated with hemolysis, acalculous cholecystitis, positive HIDA but no stones seen in a sick ICU patient, Maritzi syndrome, remember stone in the cystic duct pushing on the common bile duct but no stone actually in the common bile duct. PBC, positive antimitochondrial antibody, fat-soluble vitamin deficiencies, treat with ursodiol, which could decrease mortality and need for liver transplantation. PSC, IBD patients with increased alk phos. So liver disease, we're going to talk about viral hepatitis, drug-induced liver disease, and some hereditary conditions associated with liver disease. So just to talk a little bit about liver tests in general, with viral hepatitis, the ALT is often higher because toxicity is more liver specific. So everyone remembers that ALT is much more specific for the liver than AST. AST could be seen in a variety of other organs, including or systems, including muscle. And if you see a patient with transaminases in the thousands, there are really not that many things that could do that. So liver ischemia, HSV, CMV, a drug reaction, and acute viral hepatitis would be your main differential for AST, ALT in the thousands. Causes of elevated alk phos, in addition to coming from the liver, could include bone, kidney, intestine, and placenta. So there is a test you could order called a fractionated alk phos that could look for these different sources of the elevated alk phos. The GGT rises in parallel with alk phos from the liver, so that's a great test to order if you have an elevated alk phos and you want to see if it's liver related. When you're talking about bilirubin and jaundice, there's unconjugated hyperbilirubinemia and conjugated bilirubinemia. In this slide, we're talking about unconjugated hyperbilirubinemia. So this can be seen with overproduction of bilirubin, for example, from heme breakdown during hemolysis, or if there are defects in uptake or conjugation in the liver. So Gilbert's, exceedingly common. All right, 7% of the population, it's a benign inherited disorder of bilirubin conjugation due to a gene defect in bilirubin glucuronidation. And triggers include fasting, illness, like such as a cold or flu. So I'm sure you see this all the time in your clinic. You just have to make sure that it's unconjugated bilirubin and not conjugated. Crigler-Najjar syndrome is an inherited disorder of bilirubin conjugation, could be severe and present in infancy, and then obviously hemolysis is going to lead to high levels of unconjugated bilirubin, like in sickle cell disease. If you see conjugated hyperbilirubinemia, that's really associated with cholecystasis. And what cholestasis is its decrease in bile flow due to impaired secretion of hepatocytes or obstruction of bile ducts, for example, from a CBD stone or cholangiocarcinoma. You could also have acute and chronic liver injury, such as viral hepatitis or obstructive jaundice. Well, actually, I just mentioned that before. That could cause conjugated hyperbilirubinemia. There are inherited forms of this. So there's something called Dubin-Johnson's. And the key to this is that you'll get a dark pigmentation accumulating in the liver. And then there's something called Rotor syndrome, which is the same as above, but there's no pigment in the liver. And then another point is that unconjugated bilirubin is tightly bound to albumin, and this complex cannot pass through the glomerulus, so it won't show up in your urine until you have conjugated bilirubin. So if you see bilirubin on your urinalysis, it's from conjugated bilirubin, not unconjugated. So when you're assessing the severity of liver disease, there are really two main classifications. There's the Child-Pugh score, which could be A, B, or C. It's a calculator that you plug in variables depending on grade of hepatic encephalopathy, ascites, bilirubin elevation, degree of low albumin, and prothrombin time prolongation. And then there's the MELD score, which is really used to help determine whether people are ready for transplant. And it's a calculator based on only three variables: creatinine, bilirubin, and INR. I think this is fair game and a really important score to know about. This is a slide that just talks about what antibodies look like in the different forms of viral hepatitis. I'm going to go through these in subsequent slides, but this summary slide is here if you need it. So for hepatitis A, this is an RNA virus transmitted by the fecal-oral route. Traditionally, or typically, jaundice begins 3 weeks after exposure with prolonged cholestasis up to 4 weeks possible. I should mention that the majority of people will have symptoms. but most people will just fully recover. But it is generally a symptomatic form of acute hepatitis. There's about a 1% chance of fulminant hepatitis. There is the Hep A vaccine, which is given as 2 doses greater than 6 months apart, and some important groups that you would want to consider vaccinating either on a test or in your clinic would be all children at 1 year of age, endemic areas, chronic liver disease, like for example, fatty liver or HIV. And then if you have been exposed to hepatitis A, then there's something called post-exposure treatment. So you would give hepatitis A vaccine and or immunoglobulin after someone has been exposed to hepatitis A. And just as an aside, the CDC is a great resource they have all kinds of lists on details on vaccinations. So hepatitis B, hold on 1 second. Key points regarding hepatitis B is that if you see hepatitis B surface antigen on a blood test, it means you're producing Hep B virus. Hepatitis B surface antibody specifically indicates either past exposure to virus or vaccine, and it indicates immunity. Hepatitis B core antibody means that you have been exposed to wild type virus. This will not increase if you've been exposed to a vaccine. It could be seen early on as IgM during an acute hepatitis B exposure, and then it will become an IgG-based antibody. Hepatitis E antigen correlates with quantity of intact virus and infectivity. So hepatitis E antigen means that there's more virus around and you're more likely to infect others. Maternal to fetal transmission is more likely if you're Hep E antigen positive. When you have acute hepatitis B, this is kind of like the classic thing you've probably been seeing from med school. This just shows the different serologies that happen over time here. So initially you'll see hepatitis B surface antigen and E antigen be present, and then these drop off if you're able to clear the virus. And then there's this core window period where the only evidence that you have been exposed to hepatitis B would be a positive Hep B core IgM, because the hepatitis B surface antigen is gone, but you haven't developed the hepatitis B surface antibody yet. So that's kind of like a classic testable thing, would be the core window in acute hepatitis B exposure and clearance. So in contrast to hepatitis A, most patients with Hep B are actually asymptomatic with no jaundice, but some patients could get jaundice or even fulminant liver failure. Some could get serum sickness like picture with arthralgias and fever. And in general, it's usually supportive care, but in some cases, particularly if it's a severe course or protracted course, you may need to give antiviral therapy. With regards to hepatitis B vaccines, some important people to consider vaccinating would be obviously universal vaccination in neonates, regardless of the Hep B status of the mother, higher risk adults, so healthcare workers, dialysis patients. Post-vaccination testing to assess titer is done in patients at high risk for continued exposure. So not everybody, but if you're a healthcare worker, that would be a good person to make sure you're mounting a response. Or it could be done in those less likely to mount an immune response. So for example, immunosuppressed patients. Similar to Hep A, you could give immunoglobulin after exposure, for example, a needle stick. Usually you want to do that within 24 hours and you want to give the vaccine at the same time. And then the immunoglobulin and vaccine could be used in other potential exposures as well, such as ocular, like a blood splash or mucosal splash, or even sexual contact. Continuing on with the vaccinations, for Hep B in pregnancy, generally you're going to give Hep B immunoglobulin and vaccine to the neonate. I think that's a key testable point. An individual with acute Hep B, you want to give the immunoglobulin and vaccine to sexual contacts of this individual and infants cared for by this individual. And again, the CDC, not really for the test, but the CDC just in general for taking care of your patients, has great summaries of vaccinations. So chronic hepatitis B, this occurs when virus has been present for more than 6 months. The risk of chronicity is about 90% for infants when they're exposed, compared to 5% of adults. So if you're exposed to Hep B as an adult, fortunately you have a much less chance of having chronic hepatitis B. There are really 2 types of carrier states. There's the inactive carrier that we've all heard about. So this patient is asymptomatic with normal liver enzymes, and generally you're not going to treat this patient, but if the patient becomes immunosuppressed for whatever reason, if they develop IBD and they need Remicade, or if they develop cancer and they need chemotherapy, these patients are at risk for reactivation of their hepatitis B. Even if the surface antigen is negative, but they have a positive core antibody, those patients may need to be put on prophylactic medicines in the setting of immunosuppression. And then there's the chronic active Hep B patients that have abnormal liver enzymes. So when you're working this up, obviously you want to do basic labs. You want to look at a platelet count because it could be low if they're cirrhotic. And then you want to just send off a slew of the hepatitis serologies, including a Hep B viral load, B surface antigen, et cetera. So in terms of treatment for chronic Hep B, it's fairly complex, but I tried to really kind of tailor it down for your test. It really depends on the Hep B surface antigen status, E antigen status, the degree of viral load elevation, and whether or not the patient has cirrhosis. So generally, if the patient is E antigen positive, you're going to treat if the viral load DNA is greater than 20,000 and the ALT is greater than 2 times the upper limit of normal. If the E antigen is negative, your treatment threshold for DNA is actually lower, and you're going to want to treat over 2,000 as opposed to over 20,000. Generally, if you see this on a test, most cirrhotic patients are going to get treated, regardless of their viral load or whether their liver tests are elevated. If these things are kind of off, or the viral load's low and the ALT is high, you may need to do a liver biopsy because that could help you decide whether you're going to initiate treatment. The 2 most common medications you're going to see are going to be tenofovir and entecavir. Sometimes pegylated interferon is used. This is generally used in younger patients because the treatment course is shorter, but there are higher side effects with pegylated interferon. A word on hepatitis B and HCC, or hepatocellular carcinoma. There's about a 2% conversion per year, or a 20% lifetime risk. Generally, if you have a Hep B patient who's cirrhotic, you're going to want to screen them every 6 months. However, even if the patient is non-cirrhotic, okay, key point, non-cirrhotic, there are important groups that you need to screen. So people with active Hep B with abnormal LFTs, if there's an elevated viral load, if there's a family history of HCC, if you're African American or of African descent, if you're an Asian male over 40 or an Asian female over 50, those people will get screened regardless of whether or not they have cirrhosis. And generally, you're going to screen with a sonogram plus or minus an AFP. The American Association for the Study of Liver Disease gives you the option of adding the AFP to screening. So it's not mandatory, but a lot of people do add the AFP to the sonogram. Some centers even alternate with a CT scan, but that's kind of off the guidelines a little bit. Alternate sonograms and CT scans because the CT may be a little bit more sensitive. So hepatitis C, transitioning to this, second only to NAFLD for the number of new cases per year. It's mostly genotype 1 in the US, and 25% of HIV patients are actually co-infected with Hep C. Most patients exposed to Hep C will develop chronic Hep C. So it's important that you follow these patients up with a viral load. 25% of patients with chronic Hep C will get cirrhosis within 25 years. And I hope everyone knows about this, but all baby boomers, this is a guideline, need to be screened for hepatitis C with a hepatitis C antibody. Everybody, every baby boomer. So if you're born between 1945 and 1965. You also want to screen if there are risk factors, so IV drug use, contaminated blood product exposure, dialysis, etc. Hepatitis C and HCC. Chronic Hep C with cirrhosis is when you're going to do HCC screening in Hep C. So that's a little bit different than Hep B, right? I was saying in Hep B, there are a lot of non-cirrhotic groups that are going to get screened for HCC, but really the main risk factor for HCC and Hep C patients is cirrhosis. However, some do suggest screening patients with advanced fibrosis, not just cirrhosis. So stage 4 would be cirrhosis. Stage 3 is advanced fibrosis, and a lot of people will screen stage 3 and 4 patients as well. There's some associated conditions that you should be aware of that are associated with Hep C, so mixed cryoglobulinemia. This could present as a small vessel vasculitis with a rash consisting of palpable purpura. Could also be associated with immune complex glomerulonephritis, lymphoma, and porphyria cutanea tarda, which is photosensitivity leading to skin blistering. So here's a slide showing an ischemic toe in the setting of palpable purpura with mixed cryoglobulinemia. And then here you could see the blistering skin lesions from porphyria cutanea tarda that's associated with hepatitis C. Treatment of hepatitis C, this is like a really detailed subject, but there's so many new medicines that I don't think it's really worthwhile for memorizing these things. Generally, the guidelines are constantly evolving. I think what you really need to know is that we used to treat with pegylated interferon and ribavirin, but now we have a number of direct-acting antivirals that are much better than pegylated interferon and ribavirin. And these could actually cure hepatitis C in more than 95% of cases with almost no side effects. And frequently, you could treat in 12 weeks or less. So I think those are the take-home points regarding treatment. Hepatitis D, the key thing about this is that it requires coexistent Hep B. So it can occur acutely with a Hep B at the same time, so that's called a co-infection, or it could occur as a superinfection, meaning that someone has Hep B for many years and all of a sudden they get Hep D on top of it. And that could lead to what looks like a Hep B exacerbation, but it's actually a Hep D superinfection. Immunity to hepatitis B with positive surface antibody implies immunity to hepatitis D. And again, suspect this if you have a patient with Hep B who all of a sudden has a sudden decompensation. You definitely want to check Hep D serologies to see if they have superimposed hepatitis D. Hepatitis E, you've probably heard about this because it's associated with a high risk of fulminant hepatic failure in pregnant women, particularly in the third trimester, as I mentioned down here. Transmission can vary. It could be fecal contaminated water. It could be from contaminated meat and shellfish, or even from blood transfusion. It's found globally, but it's really more common in the Far East, Africa, and Central America. Most patients are asymptomatic and clear the virus. If you do develop symptoms, however, patients will frequently have neurologic symptoms, including meningitis and neuropathy. So viral hepatitis pearls, Hep A, majority of infections are in fact associated with symptoms, but most fully recover. Hep B, in contrast, most people are asymptomatic with no jaundice. Hep B carriers who need immunosuppressive meds may require prophylaxis, so that might be chemotherapy or IBD meds. Multiple non-cirrhotic, the key being non-cirrhotic Hep B patients require HCC screening. Hep C, you're generally going to screen cirrhotic patients, but some people screen stage 3 patients as well. I do that myself. You need to screen all baby boomers for Hep C. That is a guideline. Hep D requires coexistent Hep B, and Hep B could be lethal in pregnant females. So I think those are the key points from viral hepatitis. So autoimmune hepatitis, this is seen more commonly in females than males. Often patients are in their 40s or 50s. It can be asymptomatic, or it could present with acute liver failure. There are really two types. There's type 1, which is the classic type, and it's associated with a positive ANA, which is actually very sensitive but not that specific, and a positive smooth muscle antibody, which may be more specific than ANA. Some people actually check an anti-actin antibody, which is actually a better test, but it's not really widely available. And then there's type 2 autoimmune hepatitis, which is associated with the anti-LKM antibody or the anti-LC1 antibody. This is just a slide showing a scoring system to try and figure out how likely it is that somebody has autoimmune hepatitis. So here's the ANA and the smooth muscle antibody. The higher the titer, the more points you get. IgG levels, if you have an elevated IgG, the higher the elevation, the more points you get. If the liver biopsy is more consistent, I mean, that's pretty obvious. You know, you're going to be more likely to have autoimmune hepatitis. And if you don't have viral hepatitis, that's more points. So basically, you kind of use this, and the more points you have, the more likely it is that you have autoimmune hepatitis. Liver biopsy really will confirm autoimmune hepatitis, but it's not always done. You can kind of see a theme here, right, where we're kind of moving away from liver biopsies and really making more diagnosis based on clinical scenarios and serologies. If you did do a liver biopsy, it might show a portal mononuclear infiltrate. And generally, you're going to treat if there's elevated transaminases, elevated IgG, abnormal histology, or symptoms. The two medicines that you're going to see would be prednisone and azathioprine. There's no cure. Patients are often on medicines for long periods of time, and liver transplant is indicated for end-stage disease. So now we're going to talk a little bit about drug-induced liver injury. We're kind of getting close to the end here. There are two types. There's pure cholestasis and mixed cholestasis. Generally, mixed cholestasis is worse. That means the bili and the ALT are both elevated. There are really two main mechanisms. There's dose-dependent, and then there's idiosyncratic. Idiosyncratic is the most common. A good example of dose-dependent would be acetaminophen. So for acute drug-induced liver injury, acetaminophen is the most common cause, followed by antibiotics. For chronic drug-induced liver injury, classics would be methotrexate. That would be one of the most common. For pure cholestasis, anabolic steroids and oral contraceptives. And for mixed cholestasis, amoxicillin clavulanate would be a typical test question answer. For acetaminophen, I'm sure most people know this. Acetaminophen is detoxified through the P450 system to NAPQ1, which is liver toxic. Glutathione reduces NAPQ1 to non-toxic metabolites. And then alcohol, if you're drinking while you're taking Tylenol, it induces the P450, so this increases NAPQ1, so this increases the risk of acetaminophen toxicity. Also, alcoholics may actually have decreased levels of glutathione, which would help protect you, so that is a bad situation. So generally, if you suspect Tylenol acetaminophen toxicity, you want to check levels, you want to check an INR, you want to check liver tests. Key point, if it's less than 4 hours since ingestion, you could give activated charcoal. If it's after that, you're generally going to treat with N-acetylcysteine, comes in PO and IV forms, and you want to treat as early as possible, ideally prior to the ALT increase. Alcohol could definitely cause liver injury. Generally, you're going to see an AST-ALT ratio of greater than 2 to 1. I'm sure everyone's seen the formula of the discriminant function here. I'm not going to go through the formula, but if you see a discriminant function level greater than 32 in the setting of alcoholic hepatitis, you're going to want to treat the patient with prednisolone. Sometimes you could also treat with pentoxifylline, particularly if there's a contraindication to steroids. Other drug-induced liver injury would be methotrexate. Remember, that's a medication that's used in Crohn's disease. That could actually cause indolent liver damage without even an elevation of liver tests. So a lot of times people get periodic biopsies, even if their liver tests are not elevated. Oral contraceptives could be associated with various liver manifestations, including hepatic adenoma, pileosis hepatitis, which are cystic blood-filled cavities, and something called focal nodular hyperplasia, which is a non-malignant hepatic tumor. NAFLD, this is exceedingly common, and I'm sure you see it all the time in your clinical practice. So really, this is hepatic steatosis with no other etiology, so no alcohol use, which could also cause fatty liver. Other causes of fat in the liver include alcohol and meds. A classic would be amiodarone and Wilson's disease. NAFLD is actually the most common liver disorder in Western countries. And risk factors are pretty obvious: diabetes, obesity. If you see fat and inflammation at the same time, that is NASH, or non-alcoholic steatohepatitis. And if you see the ALT ratio, ALT greater than AST, that is seen in NAFLD as opposed to alcoholic liver disease, where it's reversed. So AST is greater than ALT in alcoholic liver disease. So the diagnosis is often radiologic. We'll pick it up on a sonogram. Sometimes we do a liver biopsy, but this is not really done frequently anymore. There's something called vibration-controlled elastography, which could actually vibrate the liver and try and figure out how much fibrosis there is. There are clinical scores like the AST to platelet ratio index that could help identify the risk of cirrhosis. Generally, the treatment is not particularly standardized. Obviously, you're going to recommend diet and weight loss. You want to make sure that they're vaccinated for Hep A and B. And if they're cirrhotic, you want to proceed with HCC screening because there are a lot of patients with NAFLD that are walking in with HCC. So screening is really important. So cirrhosis, here are some typical exam findings. So we know most of these. This is an example of a spider angioma. Complications, we've already discussed this, include hepatocellular carcinoma. Most patients have cirrhosis. It could be associated, HCC could be associated with chronic liver disease of any type. And generally, as we mentioned, we're going to screen cirrhotic patients every 6 months generally with a sonogram, possibly with an AFP. You also want to screen some non-cirrhotic Hep B patients, which we discussed before, and possibly stage 3 Hep C patients. And you really want to consider HCC in any cirrhotic who decompensates suddenly with no obvious reason. Treatment, generally, if the patient is non-cirrhotic, you may be able to get away with a surgical resection. However, if they're cirrhotic with portal hypertension, you're going to want to do a liver transplant. And the Milan criteria state that if you have a single lesion less than 5 centimeters or up to 3 lesions less than 3 centimeters, they could be eligible for liver transplants. And if they have advanced disease, sorafenib would be a chemotherapeutic option. Esophageal variceal hemorrhage, 1/3 of varices will bleed with a 30% mortality rate. Only 50% stop spontaneously. Size is a very important predictor of variceal bleeding. The larger the size, the higher the risk. There's something called the hepatic venous pressure gradient, which really is an estimate that IR could obtain by doing a wedged hepatic vein pressure, and it really just estimates the degree of portal hypertension. The key here is that if it's over 6, there's portal hypertension. If it's over 10, varices form, and if it's over 12, varices bleed, and you could develop ascites. For variceal bleeding, the primary therapy is banding that we do by endoscopy. You also want to give the patient octreotide, which is a splanchnic vasoconstrictor, and it decreases filling of varices. All patients with bleeding varices need to get prophylactic antibiotics. If you can't control the bleeding, you frequently will need to put a Blakemore tube in to compress the varices, or you may need to send the patient for a TIPS, which decompresses the portal system and will decrease filling of varices. Primary prophylaxis in the setting of to prevent bleeding. Generally, if the varices are small and there's no high-risk stigmata, you generally don't have to start anything. But if the varices are small and there's high-risk stigmata or advanced liver disease, you're going to want to start the patient on a beta blocker. And if the varices are larger, a lot of times you're going to do banding as prophylaxis. For secondary prophylaxis, meaning if the patient bled already, you want to do 2 things. You want to do banding and beta blocker together. Hepatic encephalopathy, this is frequently seen. This is reversible brain dysfunction and liver failure. It's associated with high ammonia levels. It could be due to extrinsic liver issues or vascular issues. So TIPS could actually shunt ammonia and cause past the liver, which could lead to hepatic encephalopathy. Serum ammonia levels don't necessarily correlate with the degree of it. Things that could increase hepatic encephalopathy include upper GI bleeding and SBP. You want to avoid restricting protein because liver patients are malnourished to begin with. Treatment would include lactulose, which will decrease ammonia levels in the gut. And you could also try rifaximin and neomycin, although neomycin is infrequently used because it has a lot of side effects, including nephro and ototoxicity. Hepatorenal syndrome, I'll just kind of go through this quickly. This was probably in your renal lecture already. Generally, in hepatorenal syndrome, you're going to get vasodilators in the blood that lead to a secondary clamp down of the renal artery, and that leads to elevation in creatinine. There are really 2 types. There's type 1 hepatorenal syndrome, which is the more severe type, and then there's type 2, which is less severe. So management includes IV albumin infusions, and then this is probably covered in renal. Midodrine, octreotide, and terlipressin generally will help increase blood flow to the kidneys and are used for hepatorenal syndrome. Really, the final 2 complications of cirrhosis are ascites. So generally, the key number here is a serum to ascites albumin greater than 1.1. That is consistent with portal hypertension, so that would be typical of cirrhosis. If the SAG is less than 1.1, it's non-portal hypertension related. So for example, TB or malignancy. Another key thing to look at is low total protein. This is mainly in cirrhotics. So if you see low total protein in the acidic fluid, that means that patients are at higher risk for infection because if you have low total protein in this acidic fluid, you have low levels of opsonins, which could help fight infection. Spontaneous bacterial peritonitis, the most common sign would be fever, but you could also see abdominal pain and change in mental status, although most patients may have none of these. A lot of patients will have no symptoms or signs. The key number here is a fluid neutrophil count greater than 250. You must consider SBP if there's deterioration in any patient with ascites, and the usual suspects are E. coli and other gut organisms. So key points for treatment, you want to treat with broad spectrum antibiotics. IV albumin on day 1 and day 3 will actually decrease mortality. And there's some details here on prophylaxis that we're kind of running out of time, so I'm not going to go into detail. But the bottom line is if you have low total protein, you're at higher risk for infection. Low total protein in the ascites, and you're going to want to consider prophylaxis. And there's something called secondary bacterial peritonitis, which is really due to a ruptured small bowel or colon. And Here, you're going to see different test results. So you're going to have a high protein, low glucose, et cetera. And the mortality is about 100% if you don't go to surgery. Okay. Treatment of ascites, one of the key things you want to do is you want dietary sodium restriction and water restriction. And then patients are often treated with spironolactone and furosemide. The absence of peripheral edema would be a risk factor. If there's no peripheral edema, you may be more likely to trigger renal failure if you over-diurese patients. When you do large volume paracentesis, you generally want to replace albumin. And TIPS could sometimes be used in the case of refractory ascites. So pearls for cirrhosis, HCC, you generally want to transplant for a single lesion less than 5 centimeters or up to 3 lesions less than 3 centimeters. That's the Milan criteria. Acute variceal bleeding, you want to use the combination of banding and octreotide. Antibiotics decrease mortality in bleeding cirrhotics. And if you see a SAG greater than 1.1, that's associated with portal hypertension. SBP is associated with greater than 250 neutrophils. And in SBP, IV albumin on day 1 and day 3 can decrease mortality. So hereditary liver disease, hemochromatosis, this is an inherited form of iron overload. You need to distinguish this from secondary iron overload, like for example, in sickle cell disease or thalassemia. There are multiple types, but type 1 is the most common, and it's associated with the HFE gene, which is autosomal recessive. Hemochromatosis can be associated with cirrhosis, HCC. It could be associated with diabetes due to iron deposition in the pancreas and iron deposition in the skin. That's where you get the bronze diabetes terminology from. It could also lead to arthritis and hypogonadism. And HCC, usually if there's cirrhosis, very, very high risk, and the number 1 cause of mortality in hemochromatosis patients. Generally, we want to screen with iron studies. So if you see a SAT greater than or equal to 45% and or an elevated ferritin, you're going to want to send off an HFE genotype, which is a blood test. And the most common result would be a C282Y, genotype. Liver biopsy is not always required. You really only do that if you want to assess the severity of fibrosis. So that's really what you're looking for. And treatment is phlebotomy. You want to aim for ferritin below 50 to 100. And you want to consider screening family members because it is a hereditary disease. Wilson's disease, another hereditary form of liver disease, autosomal recessive. So in this situation, you can't incorporate copper into ceruloplasmin and excrete it into the bile. So copper, there are high levels of copper in the blood, and it deposits in the liver and in the brain. And it typically presents as liver disease and or neurologic dysfunction in adolescence. So if you were to do testing, you'd see a low ceruloplasmin, and you would see accumulation of copper in the liver, which could lead to inflammation. And you would see something called Kaiser-Fleischer rings. This is a very testable thing. So these are pathognomonic, and this is a picture of a Kaiser-Fleischer ring where you could see copper deposition at the corneoscleral junction. Generally, children are more likely to present with liver disease and older patients with neuropsychiatric disease. Liver biopsy can confirm the diagnosis, but we frequently don't always have to do this, particularly if Kaiser-Fleischer rings are present. And the main treatment here is chelation. So you want to give chelating agents like penicillamine or trientine that bind copper and allow you to excrete it. And then there's maintenance chelation phases as well, and avoiding foods with high copper, such as nuts, chocolate, shellfish, and mushrooms. But the only real treatment is transplant. This is the last of the hereditary liver diseases. So there's alpha-1 antitrypsin. This is a serine protease inhibitor that folds and it is not released from the liver, and it damages the liver. It's actually a protease inhibitor. So if that is not released from the liver, it can't inhibit elastase in the lungs. So that leads to lung disease. And generally, you want to check a serum alpha-1 antitrypsin level, and you could actually do a genotype to look for whether it's definitely present or not. Liver disease during pregnancy, we know about these. There's hyperemesis gravidarum, which is seen in the first trimester. Intrahepatic cholestasis of pregnancy, which is seen in T2 and early T3. This is actually associated with increased serum bile acids and can lead to fetal morbidity and mortality. It's treated with URSO. There's HELP syndrome and acute fatty liver pregnancy, which are often seen later on in pregnancy, and both are associated with pretty bad maternal outcomes. Liver transplants would include indication cirrhosis with complications such as HCC or Wilson's disease. Generally, for chronic liver disease, you want to start the evaluation at a MELD of 10, and patients become candidates once the MELD reaches 15 or higher. And MELD exception points can be given to transplant candidates to be transplanted at a lower MELD, for example, if HCC is present. So nutrition, we just only have a few slides with this and we're done. So there are water-soluble vitamins that are generally not stored in the body. An exception is vitamin B12, which could be stored in the liver. Then there are the fat-soluble vitamins A, D, E, and K. And then there are other entities associated with nutrition, including electrolytes and trace elements. This is a quick question, last question. 46-year-old executive had her gallbladder removed 2 days ago. After presenting with right upper quadrant pain and fever, you're consulted by the surgery resident after the patient develops ophthalmoplegia and nystagmus. What likely led to this condition? Side effect of anesthesia during surgery, IV dextrose prior to giving thiamine in an alcoholic, use of tricyclic antidepressants, or urinary tract infection. Right, so everyone got this. So this is pretty typical of thiamine deficiency. And what is the treatment? Give thiamine immediately, give pyridoxine immediately, high flow oxygen, mannitol, and neuroconsult, or give thiamine slow drip. Right, so you got to treat this immediately. So specific vitamin deficiencies, B1, thiamine, associated with wet beriberi, which is associated with heart failure, dry beriberi, which is associated with neuropathies, Wernicke encephalopathy, and Korsakoff syndrome. So Wernicke encephalopathy is more of an acute state of confusion with ataxia and ocular motor dysfunction, whereas Korsakoff syndrome is more chronic. Other vitamins would be B12, riboflavin, which is associated with angular colitis and glossitis, vitamin B3, niacin, which is associated with pellagra, which typical manifestations would be dermatitis, photosensitivity, diarrhea, and dementia. Vitamin B6 is pyridoxine, which is, again, associated with various skin manifestations. Unfortunately, the only way to deal with these are just memorize them. This is an example of angular cheilitis here at the corner of the mouth, and this would be glossitis. This is a patient with pellagra, so it's the 3Ds, dermatitis, diarrhea, and dementia. B12, an important vitamin to consider. We talked about this when we were talking about TI resection. So basically, B12 is in food. It's hydrolyzed by stomach acid. It binds to an R protein in the stomach that is then hydrolyzed again, and then it binds to intrinsic factor. Anything interfering with this process, such as low stomach acid, celiac, small bacterial overgrowth, TI disease, etc., will lead to B12 deficiency. When you check labs, you'll see elevated levels of both homocysteine and methylmalonic acid. That's a tip-off that vitamin B12 deficiency is significant. You could see peripheral neuropathies, and you could see something called subacute combined degeneration of the spinal cord, which involves both the dorsal and lateral horns of the spinal cord. So the dorsal horns are involved with proprioception, so that could be a key tip-off of vitamin B12 deficiency. And because B12 is stored in the liver, it could take months to deplete. Folate could be depleted very quickly, especially in alcoholics, because they're limited body stores. In this case, you'll see a normal methylmalonic acid, but increased homocysteine, and just like B12, it's associated with macrocytic anemia. Vitamin C deficiency is associated with scurvy, so you get issues with collagen and connective tissue. So you could get petechiae, ecchymosis, purpura, perifollicular hemorrhage, etc., poor wound healing. Vitamin C overdose could lead to an increased incidence of oxalate renal stones, false negative stool guaiac. That could be a test question, and even iron overload, because vitamin C helps with iron absorption. Vitamin D is associated with bone disease, so rickets and osteomalacia in adults. Vitamin A, the key thing here is night vision. So if there's a deficiency, a tip-off on a test question would be night blindness. Chronic toxicity could be associated with liver disease because it could actually accumulate in the stellate cells of the liver, and chronic toxicity can be associated with bone disease as well. Vitamin E is an antioxidant. It protects cell membranes. Deficiencies are associated with neuropathy and anemia. Excess vitamin E, I'm sure you've seen this in the medicine literature, is associated with all-cause mortality. So you have to be careful about just kind of blindly prescribing vitamin E supplementation. Vitamin K is found in green leafy vegetables. You'll see deficiency in liver disease, malabsorption in antibiotics. It's associated with bleeding, bruising, and increased INR. Some other nutrition testable items would be magnesium. So magnesium can be seen in PPI use, and so that would be a good association on a test question. Magnesium deficiency is associated with tetany and seizures. Copper deficiency could be associated with microcytic hypochromic anemia, which could be confused with iron deficiency anemia. Zinc deficiency can be associated with impaired taste and various rashes. Selenium deficiency is associated with cardiomyopathy and skeletal muscle disorders, and iron deficiency is pretty obvious. It can be associated with microcytic anemia. And again, sorry to blast all these at you. It's just basically memorization. So enteric feeding versus TPN. Generally, as I mentioned before, we want to do enteric feeding. It's a better option because there's mucosal integrity of the small bowel intestinal wall. TPN could be associated with a variety of side effects, including elevated liver tests and even cirrhosis. PEG and PEDG tubes are helpful, but they will not prevent aspiration. So those are important points. Malnutrition, generally if you see someone with a body weight less than 80% of recommended body weight, that's obviously a key tip-off that malnutrition is present, as would be a low albumin or prealbumin. There's something called a 24-hour urinary creatinine, which could help estimate muscle mass. And there's something called a creatinine height index, and generally, if this index is greater than 80%, it indicates normal protein status. You do have to be aware of refeeding syndrome in patients with chronically malnourished patients. They could get large intracellular shifts in electrolytes, and they could get low phosphate, potassium, etc. And you can even see cardiac atrophy that develops. And then if you give them IV fluids, they could be put into heart failure. So nutrition pearls, this is the last slide. So thiamine associated with beriberi, Wernicke encephalopathy, and Korsakoff syndrome. Niacin, remember the 3 Ds, dermatitis, dementia, and diarrhea. Vitamin D is associated with subacute combined degeneration of the spinal cord. Vitamin C is associated with scurvy and poor wound healing. Vitamin A is associated with decreased night vision. And magnesium deficiency is frequently seen with PPI use and can be associated with tetany and seizures. That's it. All right.